where we really hope during the course of the next few hours to share some ideas about how together we can build healthier societies, and particularly how we can start giving a stronger and more focused approach to prevention in our efforts. And I'll speak a little bit more to that later. We have entered the 21st century, and we will be tweeting and encouraging active tweeting, and you can see the addresses there as well as the hashtag we're using for this. We're also being live streamed, so everything that is said will be taken down and used for you to advance the cause, and we hope that we'll have a lively discussion. Let me just ask Michael and Jeff to briefly come up and also give their welcomes. First, really fantastic to be in Atlanta with two colleagues who I've had the privilege to know and work with in different guises for many years. Jeff, I'd like to think, has guided some of my work in interesting ways through a career that's gone through public, private, and other related areas, and he's remained the stalwart of reminding us all about the value of public health and the centrality of prevention in it. And Michael and I started work a number of years ago on tobacco when he was heading the tobacco program at CDC, and we were able to take it global. And for him, it's a particular pleasure to be here in what I believe is the newest, if not one of the newest schools of public health in the country, and one I know that will go great places. So let me just ask Jeff and Michael to give a word of welcome, and then I'll get going.
Thank you, Derek, and thank you all for being here. It's a very important meeting, and one that hopefully will be the beginning of a dialogue that will make the difference in the lives of people around the world. We're particularly pleased to host this at Georgia State University. This is the newest building on the Georgia State campus. This used to be the Atlanta Life Insurance Company, a very historic company in Atlanta, the first African-American owned insurance company in the nation. Had this as its headquarters, and the university was fortunate to acquire it, and it's become the front door of the university. It has the Welcome Center for new students, the president's office here, and this beautiful facility for conferences. So this is one of the first meetings that is being held here, and we're very proud to host it to help advance this discussion around chronic disease prevention and how can we place more of an emphasis on prevention. As Derek said, we go back 2 decades in terms of collaboration around prevention broadly, particularly around tobacco, but also around evidence of the effectiveness and the capacity to do research, not only in the United States, but globally. So this is a very important meeting and a nice culmination of work that's been started decades ago. And it's also very pleased to co-host this with Jeff Koplan, who was responsible for bringing me to Atlanta and giving me a chance to work at CDC. And it's been a very positive collaboration over the years as well. So this is the next, I see this as a nice next step forward of looking at what we can do to advance chronic disease prevention and the science of prevention, and start to move the debate from treatment only to more of an emphasis and a priority on prevention, because I think we all know that's where the opportunities lie. Jeff?
Let me add my welcome, and nice to see you here. As Michael said, that there's a lot of symbolic appropriateness to our gathering here, both in terms of the building, its background, the link of Georgia State and Emory around issues common to it here. So I think we're both delighted to serve as local hosts for Derek's program. Many of us have worked in several sectors, including private sector, government, academia, different levels of government, foundations. So we've got a good mix, and I know there's a good mix in the audience. And between the three of us, we've worked in a number of these different venues as well, all highly relevant to the purposes of this meeting and to the interplay of the partners that are going to be necessary to really affect important changes in the health of our populations. The issues of population health are always undergoing scrutiny and changes and redefinition, and this commission, I think, can do a very good job of looking at it and charting a path for the next 10, 15, 20 years in hopefully a thoughtful, creative direction that will be helpful in charting a path for all of us in what we do. So I welcome you. I'm very honored and pleased to be here, and I think it's going to be fun and interesting, both the way it's organized and the people we have with a lot to say.
Well, thank you. So let me see how this advances. Well, first, it's also always amazing when you're in a meeting and you see a number of faces from the past who've had such a big impact on what we're trying to do. And as I mentioned, Jeff and Mike, but I look into the audience, I see Bob Robinson, who years ago, many years ago, actually had an extraordinary program at CDC called Communities of Color and South Africa. How he managed to sneak in the and South Africa part, I could never figure out. But it was, for me, a deep learning experience to understand the social, racial, and economic roots of tobacco control and what we needed to address, something that I suspect over the years we have tended not to pay sufficient attention to. And maybe that's something that will come back to light while we're talking, particularly given the historic venue that we're in here today. So let me just give you a very brief sense of what is the Vitality Institute. We'd like to think that we're an impact-driven research institute dedicated to the prevention of chronic disease and the creation of a new culture of health. We recognize that while much of the discourse around chronic diseases has been related to treatment and access, or obviously incredibly important for people who have got health problems, the long-term requires us to think in different ways. We know that from a number of reports, the short and long-term economic competitiveness of the US is directly linked to the health of our workforce. And this is going to be a theme that we're going to come back to, and I'll show how the Commission understands this and believes that it's not good enough simply to talk about it. We need to think about how we can get better action on it. In developing the idea of a commission, we thought that it was critical to have a group of people representing and modeling the solutions. So people come from the public sector, whether it's the health, the military, from the private sector, investor communities, major corporations, NGOs, foundations, and academia. Part of the problem I always saw in public health was that you'd be sitting with one group of people really talking to another group. Even within the health field, you'd land up having inadequate dialogue across the prevention treatment domain, for example, let alone between nutrition and agriculture, or between activity and transport, or between the private and the public sector. We're hoping that the Commission is able to think a little bit more deeply around how we can actually find common cause. We hope that we are pursuing gaps in the evidence, and let me just give you a sense of some of the background work that has already been done. We had a look at what has been happening to research in this country as funded by the NIH and other federal agencies, and not surprisingly, show that a relatively small fraction of the NIH budget goes to prevention, if defined in terms of Institute of Medicine or CDC criteria of prevention. Many colleagues at the NIH would prefer a broader definition that is all-encompassing and would include everything from animal experimentation all the way through to theoretical work on mechanisms, because they would argue in the very long term, maybe that'll yield prevention. We are interested in a more pragmatic set of questions. How do we have a prevention research agenda that meets the burden of disease now and in the midterm? And given the size of the burden of disease and the gaps in prevention, clearly there is a gap in the focus of research in this country funded through the federal agencies. We highlight in that same report the fact that one of the golden nuggets in the federal research portfolio is the funding for prevention research centers through the CDC. Yet the level of funding is rather pitiful compared to the quantum of $30 billion being spent by the NIH generally. Another important area, and the research issue is important because we see how investment in research doesn't just yield knowledge, it yields careers for people. It builds the leadership around what is possible inside academia and in the medical world. And those people go on to make important decisions around the structure of a healthcare system. Remember that almost 60% of the NIH funding would actually go into an overhead to support medical school development. That aspect is not really spoken about enough. And we believe is terribly important because where you place your funding doesn't just yield publications, it yields people with careers and paths that can go on to direct the type of health system that is either going to focus increasingly on treatment or on prevention or some combination. We think that one of the important areas that the Commission identified related to the evolving sciences of behavioral economics and simultaneously the greater use of biotechnology and information technology in prevention. Work by Kevin Volp, George Lowenstein, and others from Carnegie Mellon and UPenn have really highlighted the value of behavioral economics in helping us think a lot more carefully around whether we truly make rational decisions about our own behaviors and whether policymakers make rational decisions. And in doing that, they draw heavily upon the Nobel Prize winners' work, Daniel Kahneman, and even more recently, Robert Shiller from Yale, in some of the way he looks at irrational markets. And the basic conclusion, which I think we all know intuitively, is that when faced with a choice, we tend to make short-term decisions that are often not in our best long-term interests. And the same is true for policymakers. The behavioral economists bring a mindset around how do we change that? What practical steps can we make to actually address improve our ability to take the long-term rather than the short-term route? And we think that is an enormous body of information that needs to be brought to the table. Other gaps in the evidence we think were important were the regulatory environment. I was interested in the fact that here we have, under the Affordable Care Act, a really unprecedented opportunity for a range of prevention measures to be implemented. One of them falls under the workplace wellness provisions. And under the workplace wellness provisions, you now can use high levels of incentives to stimulate healthy behavior, particularly related to tobacco, diet, and so on. But the wording around in the Act is quite interesting. And it says that the nature of the intervention that you use needs to be based on a criterion of reasonable design and not on evidence-based practice, which is the way we would go for a clinical intervention, whether it's a pharmaceutical product or related product. So what that basically means in simple English, when I got the lawyers to translate it for me, is that anything goes in the workplace if an employer can say that it sounds reasonably okay, which means that aromatherapy could go along this and be given equivalent weight to a very carefully constructed, effective smoking cessation or weight management program. And I think that that represents a structural problem in the way prevention is approached. So in the workplace in this country, you therefore have this situation where if you want to use a pharmaceutical intervention, it would have to be subject to the highest standards of evidence, a randomized trial and peer review and so on. When you used it, you also may not, if you are within the federal system, apply cost criteria, because by statute that is not allowed. Compare that to prevention and health promotion in the workplace, where you're applying a reasonable design, non-evidence-based criteria of anything goes, and you're expected to apply economic return on investment criteria to things that are not as strongly grounded in science. And you can start seeing that you have a bit of a distorted system where effective interventions are not actively encouraged, yet cost is very closely looked at for not effective interventions. The implications are that a system has been built that I think discourages a focus on true evidence-based prevention, particularly in the workplace. We certainly believe, and the report highlights the importance of all the different groups working together, and I won't go into that in greater detail, and the value of cross-disciplinary collaboration. I'm hoping in the course of today we will get into the value of doing some of this more practically. One of the issues that I thought quite striking when we started the work was to ask how well is the US doing relative to the rest of the world? And you've probably seen this data. A lot of it has been coming out of work both by the World Economic Forum as well as Chris Murray and his team out of the Health Metrics Unit, who've really looked at the last 20 years and asked the question, what has happened to the health outcomes of Americans relative to their peer countries in the developed world? And the answer is that over the last 10 years, the US has slipped behind, down the rankings. And it's now down to rankings between 20 and 25th in terms of life expectancy, in terms of outcomes for cardiovascular disease, in terms of outcomes for many other risk factors, about the lowest for body mass index. It does relatively well in areas where there is very effective treatment. Stroke actually being an interesting one where it's ranked fairly high compared to the peer countries. But the fact that it's low and getting worse relative to other countries suggests that other countries must be doing things differently and using their dollars more wisely. And while we don't go into that in great depth, I certainly recommend to people Elizabeth Bradley's recent book on the American paradox, where she and colleagues really compared the US to the Scandinavian countries in terms of health outcomes. But more importantly, before looking at health outcomes, she looked at values for health and societal values, because there are many in the US who would say, well, the Scandinavians are pretty wacky and socialist and liberal and communist and all these other things. So the question was, are they really? Are their underlying values different from underlying values of Americans? And they found no differences on basic issues around the propensity to want choice, the nature of the underlying politics, left, right, middle. That sort of balance was also not dramatically different. The support and the belief in a socialist state has actually changed quite dramatically, and I think there's a greater sense from the data that there's a closer proximity between the Scandinavian countries, particularly Sweden and the US, than people here are often aware of. But there were some fundamental differences, and they were really around the notion of how do Scandinavians see health? How do they define health? And I would characterize it by starting to remind people about the WHO definition of health, which says that health is a complete state of mental, physical, and social well-being, and not merely the absence of disease. I think you will find that in the Scandinavian system, they embrace the entire definition, whereas the US healthcare system has abandoned the broad aspects of a complete state of physical, mental, and social well-being and focused on ensuring that you have the absence of disease. And that is what the polling also suggests. And then the system gets built on that. When you start looking at the investments in healthcare, while the Scandinavian countries have substantially lower levels per capita of healthcare spending, they have substantially greater spending on social services and prevention services. And that seems to be making the difference. And we make that point because if you look at their outcomes, the outcomes show that Sweden, for example, now has the second best life expectancy in the world, behind Japan. Australia is third, and the US, as I said, is well down in the 20s. If we look across the US, I think we find as well some enormous opportunities for change, simply by applying what we know across the country. So one good example is people have modeled, you know very well the data on the left, the obesity data, and people have modeled what would happen if physical activity levels actually were to rise, and you could add in eating healthier as well and dropping calories and everything else. The point of this article was to show that if we were to apply what we know, we could actually reverse and change the picture across the US. There's similar data that you could apply to tobacco. The fact that we have such variability across the country, where the counties, some parts of the country, county smoking rates are 9–10%, compared to other parts of the country where they're 36 to 40%, suggests that what is going on in the best counties is eminently doable in the places in the country where we are not doing the best, without applying new knowledge. We simply need to apply better what we could across the country, and that would have big impacts on saving lives. This report hopes to point to that because it actually should be quite a positive message to show that it's not purely the lack of evidence or information we require, it's the application of it. So the Commission hopes to take some of these issues and blend them into a set of recommendations that we're hoping will be the subject of some of the discussion today. So let me just give you some of the high-level recommendations. So the first is the importance of health being embraced as a core value in society and a strategic imperative across all sectors. I won't go through the details, but let me give you a sense of what we mean. We know that, and we're talking about not just health, but the prevention of health. We know that generally the greatest opportunities for creating health lie outside of the health sector per se, and the two that we focus on very strongly are the agricultural sector and the transport and urban design sector. We know that the agricultural sector and agricultural policies have a huge impact on what gets eaten, the availability of food, the diets of people. And yet, when you actually talk to people inside agricultural departments, not just here, but around the world, they would say their primary responsibility isn't to create optimal nutrition for all, but to meet the needs of farmers and to ensure adequate productivity and yield as opposed to quality of diets. Going back to my WHO days, I did a trip down to the Food and Agriculture Organization early on and wanted to know whether they could produce some scenarios looking at what should the food supply look like 30 years from now if it met the optimal nutrition needs of all? And how could we actually meet the gaps and start addressing it? They didn't want to do it because it would touch on too many contentious issues. Clearly, grain production was going through the roof, and most of the grain was going into the mouths either of livestock, particularly beef, as well as biofuel. We knew that the expansion of palm oil around the world was having a devastating impact on the environment and on cardiovascular health. That was not something they wanted to deal with. Then there were a range of other crops growing very fast, which are wonderful to have in our diet or as part of our after-hours enjoyment, coffee, tea, cocoa, but really bring no nutritional value of substance to the people, yet do take up valuable land and a lot of water, a lot of energy, yet are lumped along with the food and nutrition crops. When we looked at fruit and vegetable supply, we realized that there was going to be a real crisis coming up over the next few years structurally. And in a country like the US, 40 to 50% of the fruit and vegetables have to be imported. The production inside the country is not sufficient to meet demand, making it more expensive relatively to be having fruit and vegetables relative to corn, soy, palm, where the pricing was low. These issues are touched on in this report. And while we don't expect there to be sudden light switches going on, we do think that we are starting to see greater synergy between those working in the fields of the environment, where they know that the consequences of an unhealthy diet are going to be devastating in terms of the sustainability of our agricultural supply, particularly the issues related to excess consumption of meat. On the transport side, we looked as well at the question of what is happening to activity, not in the schools at this stage or in the gyms, but what is happening to activities of daily living on the streets of the US, or the streets of the world. And it's very clear that we are systematically engineering out mobility in urban design. People like Jeff and others who are in China all the time, I'm sure, can probably document through their own photographs the disappearance of cycling ability and walking ability. Anybody with any concern about their lungs would certainly not walk through the center of Beijing at this time of the year and would stay indoors. Well, what are the consequences of that for obesity and for long-term health and cardiovascular disease? The problem has been, how do you talk to the transport sector? And one of the things that the report, I think, is going to highlight is that health often tends to try and say that the reason to change transport policy should primarily be for health. Well, we'll never win that argument. If it's primarily for beautification, for rising property prices, for improving the environment, for improving the quality of life in cities generally, we will win. And along the way, one of the outcomes would be improvements in the health conditions of people associated with walking or cycling. Karen was just telling me about your Atlanta skyline, or I don't know what it's called, but there we go. And I hope to learn more about it. And I've seen in New York how the equivalent skyline wasn't put up as a health-related initiative, but has huge implications for health now that it's up. And it's seen as a center for beautification. A lot of money is being poured in. Tourism is benefiting. The entire communities are benefiting. I think those kind of win-wins are the areas that we in health need to be thinking about a lot more, rather than simply making the case that we've got to increase physical activity and have cycleways to lower our obesity levels and lower our cardiovascular risks. Speaking to a town planner, that's not really going to go too far. A second important recommendation came out of a discussion I had with colleagues early on in starting the commission, when I asked them, what do you see as the most important reasons why you believe in the US prevention has not seen and got the traction it needs? And I'm very wary of even raising these issues, when I have a previous head of the CDC sitting here, who I'm sure will give us a different perspective. But they all gave me two very interesting answers. The one was that there is no unified corporate voice for prevention in the way in which there is a highly organized collective corporate voice for treatment and care. That is comprised of the pharmaceutical industry, medical devices, and hospital sectors. They speak often as one on platforms. And this is not a bad thing. This is a good thing for people who need treatment and care. But there is no equivalent balance on the private sector side with all the lobbying, all the marketing, all the power that they can bring to actually influence policy, to actually balance the voice that we see on the treatment and care side, until recently. And part of the commission has been looking at is, well, who are the voices in the corporate world, not the public sector world, in the corporate world? Who wins by a greater focus on prevention and health promotion? And what we're seeing is some strange and unlikely groups emerging. I think we would argue that companies like Microsoft, Qualcomm, Samsung, General Electric, IBM, the entire Nike-related and activity-related world, those in the food sector dealing with healthy foods, the fitness and the device companies, those involved in the gyms and the activity areas, some in the health and wellness space, all are actually forming an interesting ecology whose business model depends upon promoting health and prevention. Some of their payment structure depends upon having healthier populations to continue to be active. I mean, if you're selling running shoes, you actually want people to be able to use running shoes. So it's your material interest to do everything possible to have walkable cities, to have cyclable cities, to have people more active. If you're creating fitness devices, you know that if you are linked into other programs, people have to continue to use them. If you are creating healthy food, you actually want the profit margins to be working in your favor. I mention that because one of the interesting parts of the Commission has been this discussion around how do the investors get behind this new ecology of health promotion and preventing companies, and how can they be a far more effective organized voice to actually say that we don't only need to go the treatment route, but we need to structure our society and our incentive structures in favor of prevention. So that was the first point they made, and that is a very strong recommendation we make. I'll come back to another one later, the second one. Now I've lost my device here. Here we go. One of the big focuses, obviously, is on the workplace. And we recognize that the US is unique in the OECD world in one important respect, that the role of the employer is very different than in countries where you have a national health system or a single-payer system. Historically, as you all know, 155 million Americans depend to some extent upon their employer for work. So one of the high-level recommendations which we are interested in is based on the evolution of sustainable investing. I've been interested to see how, over the last few years, you've seen the big investment community, UBS, BlackRock, Deutsche Bank, and CalPERS and others, starting to judge companies not just by their financial reporting, but by their sustainability records as well. Not because it's a nice thing to do, but because they know that companies who are on a path to sustainable development in the way they source, in the way they do their agriculture, and even in the way they do their governance, and it also includes diversity, all of those factors have been shown to be material to the long-term bottom line of companies. So there are good research papers done by Michael Porter and Kramer and Eccles and others from Harvard and around the country showing that companies who invest more substantially in the long term in these sustainable areas and have good financial reports show a better improvement in their stock price over time. And as I said, interestingly, it includes diversity. The more diverse the workforce, the higher the level of long-term growth of the company, which is itself a very important measure. So what about health? We ask the question, where is health in all of this, given that most people accept that human capital is the most important source of capital inside a company? We spend a lot of time inside corporate America measuring the quality of the machinery. When is it going to be needed to be turned out? How well is it being repaired? What is the state of machinery? And it's seen as a strong indicator of the competitiveness of a company. Yet the most important source of capital is actually its human resource base. And the failure of it is seen in terms of rising healthcare costs to the company, lowered productivity, lower morale by the workers, low retention rates. So the question then arose is, how do we encourage employers to integrate metrics on the workforce health into their financial reports? And we have a stream of work, and we're very keen to get your reaction to this. The first time we'll go public with it will be at an investor meeting on sustainable investing in May this year, when our chair, Will Rosenzweig, will make the case based upon sound business principles. One of them is, one small piece of this, is wonderful work done by Ray Fabius, and I think Ron Getzel worked as well with them. A wonderfully elegant study which took the prize winners from the best workplace programs under the Cooper Awards over the last decade or so, and compared them to other Dow Jones companies, and looked over the 20-year period to see what happened to those companies who had the best, who won prizes because of their workforce health, what happened to their stock price over 20 years. And the result was a doubling in the stock price among the companies who had the best health of workforce as documented through a prize-winning process. Now, there are lots of issues you could say about cause and effect, but actually I don't think it really matters. I think what it shows is probably a coalescence between good governance of companies and the way they treat their workforce, which together have this generative effect on long-term wealth for companies. This is very powerful, and it's arguments that I don't think we in public health have used enough and actually elaborated strongly. Very importantly, we see the important, and I mentioned it as well, I mentioned there were two things I was told when asked why does the treatment world get so much better limelight. The one being the lack of a unified voice for prevention. The second being the reality or perception that the quality of the science in prevention is simply not good enough. And as I said, it's either the impression or the reality, and it's probably a mix. And so we actually are arguing very strongly to shift investment dollars to prevention science because of the impact that it'll have not just on knowledge creation, but also on career development and on modeling the new set of leaders, and also creating the groundswell for private investment. Remember that part of the function of part of the reality of what the NIH does on the basic science is it takes away the need for corporations in the pharmaceutical sector to do the basic science of research. Statins could be built by many companies on the platform of basic science funded through federal dollars. There is no equivalent in many areas of prevention where there is basic science done that allow corporations of the nature I mentioned then to actually expand and develop products. Let's just take the food area. We all want low salt, we want low sugar, we want changes in taste. Where is the massive equivalent investment in the basic science funded by the federal governments that then allow companies to take what we've learned and then compete with them out there in the market? Instead, what's happening is in the area of taste and salt and flavor, and having come from that sector, I know well, every company is doing their own thing, which is highly ineffective, given that, in fact, that is a pre-competitive space where legitimately the same argument goes that was applied for the pharmaceutical industry should apply to getting healthy foods. The same would be in activity devices and so on. The difference, though, that we say is that we looked very carefully at the Emory website on prevention science and many other schools, and the current definition really boils down to the first line, that it's seen as the systematic application of scientific methods to the causes and prevention of health problems in populations. And many of you here probably have to regurgitate that when asked what is prevention science. So we actually see the need, and we'd love to get discussion on adding in a few more elements. We think that the classic scientific methods, particularly epidemiology and so on, needed to be extended beyond the confines of public health. Second, we need a more explicit focus on behavioral economics and innovation in personalized technologies, the kind of thing going on inside, whether it's Qualcomm or Microsoft or some of the device companies. And third, we think that government-led interventions need to be adapted and expanded to draw upon new insights about behavior change, particularly coming from the private sector, and I haven't seen that happen enough. So the final recommendation is really to stimulate markets and business models to develop and deliver healthier products and services by investing and scaling up prevention. And this comes from people who've said, how can we make markets work for prevention? I mentioned in the beginning that the first recommendation is second one is to get a unified voice of corporate America behind prevention. Well, having the markets set up and the incentives set up to allow this to happen, we think would have a very powerful impact long-term on changing the way we actually see prevention. So with those few comments, and I hope we're going to take them into rigorous discussion, it's now a real pleasure to have Betsy lead off with some initial comments, Betsy McKay from the Wall Street Journal. And then we're going to have a discussion among us, yourselves, and we're very keen to get critical comments, ideas, thoughts around these initial set of recommendations before we move to the panels. Betsy.
Can you hear me? Better? Okay, sorry. So I just wanted to pick up where you left off and talking about the private sector. You know, people like me tend to look for tectonic shifts in areas like this, you know, a real move towards prevention. But I wonder if you could talk a little bit about how far you can actually go with that. Because at the end of the day, if you look at this country, you know, the subsidies that are in place are always going to encourage us to eat a certain type of food, which you know, has contributed to a lot of our health problems, subsidies on corn and so forth. These are major policies that can't be overturned, yet one would argue that major changes need to be made in them in order to put a real dent in obesity levels, for example. There's a glut of sugar in the world. In many countries, tobacco is a critical product for a country's economy. And as you talked about, parts of the pharmaceutical industry are incentivized to produce products that don't necessarily encourage us to live healthier, but just encourage us to be treated for diabetes or whatever. So I'm wondering, I'm sorry, maybe this is a bit of a big question, but isn't this in a sense a losing battle when you're up against such huge market forces? And how far can you really go? I mean, is this an area where you have to be satisfied with small wins and that's okay, because it'll shift the needle somewhat, or can you do something bigger?
Well, I'd love to get all of your responses, but let me just give you a starting point. I think that's a great starting point to the discussion. I think probably on January the 11th or 12th, 1964, when people opened their newspaper and read about tobacco, they never thought that it would change dramatically an entire industry. And yes, today we still have 42 million Americans smoking and 450,000 deaths. But that number would have been, as far as I can recall from Ken Warner, probably double. So change is possible. Yes, 50 years is a ridiculously long wait to actually expect things to happen. I think that you've got to have multiple bits, multiple actions by many different groups. But I just want to go back to some of the insights that I think we're getting from the worlds of, as I said, of a set of players we don't usually think of as being actively involved and researching areas of prevention and promotion. What is Samsung doing with literally billions of dollars of investment in R&D around prevention and health promotion? What exactly is Microsoft planning with their restructuring and the use of better design and better approaches to stimulate active lifestyles? What is Qualcomm thinking of when it's starting to invest also hundreds and hundreds of millions of dollars in ensuring that we have screening programs that are far more effective and far more responsive to biological changes in the body? And I could go on and on and on. What is General Electric up to with their Health Imagination initiative? And why do we never talk about that in prevention meetings? Or IBM already having made quite a lot of advances in the use of artificial intelligence in the field of oncology. What happens when Watson really gets into health promotion and prevention and starts being able to trigger some of these changes? So there is material interest in those corporations to go down this journey. And what it will do, in response, say, to your food question, I think it's going to recognize that at the end of the day, food choices are made one by one at the point of actually making a purchase. Well, the influence on consumers and the way consumers get influenced is changing quite fast. We're seeing how retailers are shifting the way they do their promotions. We've seen that discounts that we've been exploring on, large discounts on healthy foods, shift diets. We've seen that the response of companies has been steady, and declining levels of salt, sugar, fat are happening. These things are not happening fast enough, and of course, we would all like them to go faster. But I think they're starting to come together, and they're starting to coalesce far more than I ever suspected. And on tobacco, dare I suggest in front of my tobacco experts that we're sitting on potentially the greatest disruption that we could ever have in the tobacco industry, namely the growth of the non-combustible category. And if we were to move away from our ideological terror that this is a trick by the tobacco industry and just aggressively embrace some of the non-combustibles, we have the power to actually cut the death rate within a decade or two dramatically. But do we have the will to do it and the will to actually overcome some of the naysayers? who in this case actually come from public health, not from the industry. John's going to have to respond to that. Betsy, do you want to add some more comments, and then we're turned over to the floor?
Sure, I'm actually fascinated with what you just said about e-cigarettes. So are you saying that public health should embrace such products?
What I'm saying is that we have to keep our eyes open to make sure that a couple of things are in place when we do embrace them. And Michael and I and others have thought about this, I think, a fair amount. And I think the argument certainly needs to be made that current tobacco control needs to be strengthened even more. So get on and raise the federal excise tax, and the CBO have done all the work. For the e-cigarette, make sure that the regulatory environment is smart and actually stops some of the fears, the darkest fears that people have, particularly around youth smoking and around the safety standards. If that is in place, yes, ensure that we have a code of conduct among the leading companies and let them use their market capability to see how they can get people to shift. I mean, I never thought I would say that, having come out of WHO where we looked at these issues. What we failed to do at WHO was to separate a need for a nicotine policy from a tobacco policy. And today we are sitting with this big perception issue, even held by physicians in senior positions, that the risks of nicotine equate in some way to the risks of a product with tobacco. And of course, there's no equivalence. We're talking about huge differences. Hopefully it'll come up, I'm sure, in the audience.
Does anyone, I can keep going, or does anyone have a question?
Yeah, keep going for a bit, and then we'll turn it over.
Okay, well, I wanted to ask you, kind of continuing with what I asked before, this just came up in conversation over the weekend. Someone commented to me, well, a man who is over 50 said, well, I'm on statins, so I'm not as worried about what I eat anymore. And I wondered how often, in other words, this is a person who feels like, technology is helping him in a way that allows him to continue maybe not so healthy a lifestyle. I mean, he's trying to live a healthier lifestyle, but realizes that has limits. So my question is, technology can really help you in this fight and is helping, but to what extent do you think, and this is kind of a philosophical question, I'm not asking you to comment on this one person and their statin use, but to what extent do you think it works, technology and advances in lifestyle work against the prevention effort?
I think part of it relates to the aggressiveness and the visibility of marketing on the treatment side versus the lack of aggressiveness and marketing of the power of prevention. When you actually look at the evidence, and hopefully people here, I know many in the audience are far better on top of it. If you take the statin example, probably there have been fairly good studies looking at lifestyle interventions versus statins, not in people with high levels of cholesterol, but people in the sort of moderate, should we treat, shouldn't we treat range. And actually, the lifestyle interventions do very well. I mean, we've got people from the CDC who can talk about the DPP and the value of many of the diabetes prevention programs in the prevention category. Of course, when they've got diabetes, then you're dealing with lifestyle change plus medication. But the same is true in the areas of sleep. We've seen an enormous sleep industry grow up around pharmaceutical interventions for sleep. But when you look at the clinical trials, cognitive behavioral therapy and a range of other sleep interventions work as well or far better than the pills do. So while we've built a culture where there's a pill for every ill, the reality is that certainly in the moderate range of risk, the lifestyle alternatives do exist and there are clinical trials around them. They often are not made accessible, and they're also not seen by people as an easy choice. And it goes back to the issues around behavioral economics, that it sounds so much more alluring than simply to take a pill and continue eating what you're doing, particularly then if the physician is not giving you advice about saying, why don't you do both? I think one of the things we looked at, I didn't mention, is we reviewed the quality of education of doctors, public health, and nurses and lawyers in this country in terms of the proportion of time they spent on prevention. And you know the answer. It's low and has remained stunningly low for 100 years with regards to physicians. We can decide who's to blame for it. I put my blame on Flexner. But that's an esoteric discussion. Public health schools do very well, of course, on prevention, but nobody listens to them, frankly. And I wish they did, Michael. So we wanted to test that. We'd had a look at, and this is a project that I hope you'll expand, we had a look at major advisory panels in the government and across the board, and looked at what are the backgrounds of people sitting on an advisory panel dealing with behavior change or prevention. The vast majority have no backgrounds in public health, and they come out of a medical school where they may be the professor of internal medicine and professor of surgery, and I'm sure they're all wonderful people, and I would go to them if I'm sick, but not to decide on a prevention program. So, I do think that this distortion in the eyes of people is a very real one, and part of our meeting is to try and show that that need not be that way.
Thank you, Derek. First of all, I promise not to talk about e-cigarettes, to turn the meeting into a discussion on that. But I do have a more fundamental question, and it kind of picks up on Betsy's comment, and it relates to one of the reasons that we're really excited about this meeting. And I think everyone here believes in the potential of partnerships and the importance of private sector and public sector working together to achieve something that we haven't been able to do yet, which shift a paradigm. But my concern or question is the issue of the current zeitgeist in the United States is very anti-regulatory. And that, are you comfortable relying on enlightened self-interest for corporations to do the right thing with respect to advancing the public health? And we have here all the sectors, the private sector, the public sector, CDC, NGOs, all want to figure out how to work together, but there is somewhat issues around trust in certain sectors. And the current issue, which I'm sure you're familiar with and comment on, is the debate around the Trans-Pacific Partnership, where there's an effort to put in place a free trade pact with Asia and the US, and there's great concerns around corporate power and its risk to the environment, to the public health. And so, how do we move forward when there is issues of historical lack of trust or concerns, or that the focus is on the bottom line that may not necessarily include employee wellness and health outcomes, or at least not more broadly in the public? So if you could, and I know that you're well positioned to reflect on this issue.
Thanks, Michael. So for the next 2 hours, no, I think that is the crux of the issue, and I think the question of trust is obviously a multifaceted one, which has to be addressed in under 5 minutes. The person to your left, but I think I've seen in all of these sectors an interesting evolution. First, there's no question that government regulations are critically needed. They provide guidance, they provide a framework. The question is how they're done. If they are enabling legislation, if they can stimulate and really draw upon market forces and allow competition for healthy products and whatever, and services, so that the race is to the up in terms of improving health, all the better. The problem often is that regulations often kill off the potential for incentives. So, in some of the tobacco areas, absolutely they're needed. They need to be tightened. Some parts of the country, I was just hearing from Rhonda that she can't get a smoke-free restaurant in Kentucky. Well, that is just extraordinary. But I think that one thing you're missing is that corporations are not just looking to the regulation and the government in terms of what decides their behavior. They are very sensitive to what the investors are telling them. And what we're seeing through the Dow Jones Sustainability Index, which is an index which uses sustainability criteria, is that if I can remember when I was in PepsiCo and we slipped behind Coke on the Dow Jones Sustainability Index, which at the time didn't have a strong focus on many of the health issues, but it did focus on sustainable agriculture and everything else. All hell broke loose, and it was a good example of competition at work. We had to redouble our efforts around some of these things. That's why we're arguing that the metrics that get adopted by these indexes, supported by the stock exchanges, drive corporate behavior in ways that many of us here may not fully appreciate. They get read by the chief financial officer and the chief executive officer, and they get taken extremely seriously. The FTSE for Good in the UK drives that process. The Dow Jones here, the global reporting indexes of the UN Global Compact, to date they've been kind of weak on health, and that's where we think we need to get up there. But they are getting stronger and stronger on human rights in the supply chain, and that has meant that companies who previously, there's no regulations about what they should be doing about human rights way offshore in some remote part of the world, but they know that if Bloomberg financial analysts are looking at how people are sourcing labor in a far-flung country, and if there's any child labor or any hint of child labor, it'll be brought to bear in New York. Suddenly people start hiring human rights lawyers, change their supply chains far faster than any regulatory regime could bring in. And I mention that because there are a set of tools within the corporate investor world that drive behavior maybe more effectively or as effectively as government regulations. And I've been particularly interested, having spent so much of my life on the government side, seeing the power of what government can do and seeing how the failure of government as well, particularly failure of enforcement in many parts of the world, and then seeing how you can do it on the other side. And the last comment I'd say is that I don't think any pledge by a company to do well should be taken as or trusted without an independent evaluation of that impact. And I think that most companies, serious companies, now accept that. So in this country, the big example is the Healthy Weight Commitment Foundation, a pledge to reduce by some trillions of calories the amount of calories delivered into the US system, an independent evaluation funded by the Robert Wood Johnson Foundation with legally the data goes through a legal process of verification, very high levels of verification, and will get reported. If you can believe the data, then you can believe the pledge. And companies, I think that is the route to go. So any pledge without an independent evaluation, discount as being a very nice thing to do. But if it's got a pledge and it's the right pledge, I don't see how you can't actually accept it.
I wanted to go back to Betsy's 50-year-old on statins. We don't appreciate that if you've got high cholesterol, you've got high blood pressure, and you bring those down to a healthier range via medication, that actually doesn't buy you the health benefit that you would have if you had stayed at that healthy level, or if you had gotten to that healthy level through changes in physical activity, nutrition, and so on. And that's a failure of communication at the clinical level, at the public health level, and at the marketing level of these drugs. And prevention suffers from a similar overpromise, if you will. We try to drive home the point about the value of prevention and where prevention gets us, and in some cases we oversell that in terms of the cost savings to healthcare, for example. And then we're held to that standard that we can't achieve, and it makes it easy for prevention to be dismissed as really not delivering. So there's a whole area of communication that I think we really need to figure out. How do we talk about these concepts, and how do we really communicate effectively?
Great.
So can I? So I wanted to tag on to exactly what was just said. I think that was very interesting. I think part of that might be that a lot of our trials, a lot of the prevention trial data that we use to cite to large companies and to cities and others to adopt these ideas are based on extremely high-risk populations. So the diabetes prevention program, for example, that I know quite well, was an extremely high-risk group. They were going to convert at very high levels every year, year on year. And I think one of the things, as we talk about everything that Derek's commented on, I wonder, we talk a lot on the supply side, right? In terms of building programs, building ideas, corporations actually taking on prevention programs. And so the supply side, for example, with DPP, the CDC is rolling this out at YMCAs around the country. I think we're missing the other side also, which is the demand side. And the demand side, there's a huge gap there. So I'm privy to a little bit of data from a large insurance company, let's say, who's involved in a lot of diabetes prevention programs around the country. Their data showed that when they go around with large RVs to huge employers in the country, they found 380,000 people who are pre-diabetic and eligible for diabetes prevention programs. Of those 3,000, 1% actually enrolled in the program. So it just shows you this huge gap. Even knowing their risk, people don't necessarily adopt. And I wonder whether Derek or others here might comment on marketing and how we market prevention. Where should the dollars come from? And how do you market it better such that the actual individual adopts and gets into the program?
Yeah, I'm not going to answer in detail. Just to say that maybe in the break we can talk about how the Vitality program exactly was set up to try and address that very harsh reality. That when you detect somebody at risk, how do you stimulate them at the individual level? And that's also what I was referring to when we get to prevention science. That I was struck moving even to PepsiCo by the fact that when we were in public health, we focused very strongly on the broad epidemiological trends. And people always say that epidemiology are the people with the tears wiped away. The basic humanity and individualization doesn't appear in epidemiological data. Yet that's the main interest of a consumer goods company or of the private sector in general. And that notion of how you personalize the messages is something that we've tried to focus on. And I think there's a great unity waiting to happen between the broad population strategies that have tried and tested and worked so well for us and the increasing demand. And I think it is demand by people to have better choice, to have a range of choices, and the personalization demand that is starting to come from the private sector. And instead of saying this is a good or bad thing, I think we should embrace it and say it is a reality. We need to think how we can blend the two together. Jeff, and then
Derek, you drew a contrast between the private sector having a voice and a visible presence in clinical care, curative care, but not in public health prevention. I wouldn't argue that there is one for public health or prevention, but for the one for clinical care and for health care in general, where was that voice for this last decades as we've had an increase in uncovered population uncovered for care, and an increasing population with inadequate care, and support for some federal or state activities that would provide that care. I don't hear that voice, or you might have been talking about a different country, but...
Well, I think that they would be arguing in their own short-term interest that things were fine in the U.S. Why should they change? I don't think that they saw a large number of people coming in. The proof of it is in the rising healthcare costs relative to the other countries. Costs have been rising. The profitability of the pharmaceutical industry has been extremely high. The medical device companies are doing jolly well. The hospital people were doing very well under the past system. Why would they want to support change? Particularly since they don't know what it's going to mean. They didn't see the fact that they would draw in several million more people and potentially put them onto treatment and see even greater growth. So I'm not surprised they didn't fight for change. Gillian?
I have a question from Daniel Green from Ohana Foods from Twitter. And he asks, what food companies, retail and food service, do you think are doing the best job right now? Who is leading? What public food companies ignore Wall Street and optimize the long term by valuing what their people want?
Yeah, I'm not going to answer that from what I believe or feel. I mean, I meant to answer it by saying that one of our commissioners is somebody called Sabjit Nahal from Bank of America Merrill Lynch. And he's been doing interesting reviews published by Bank of America Merrill Lynch, really asking the question, which companies are starting to contribute most to a reduction long-term in obesity? And very interestingly, he's got groups of companies which include on the food side, Unilever, Danone, even PepsiCo. Those companies in the weight management area, Weight Watchers, Nike, Adidas, and some on the medication side, Novo Nordisk and others. And they list 30 or 40 stock on the Dow Jones and argue that that grouping of companies together over the next 15 to 20 years are starting to, likely to have the biggest impact on reducing obesity. And because of that, the Bank of America, Merrill Lynch people suggest to those investors interested in those that are starting to have a positive health impact should consider investing in those companies. Whether they got it right or wrong is not as important to the fact that it's still early days in the way they do their assessments. But what I think comes out of it is that, my point earlier, that investors are looking long-term, particularly the long-term investor groups, the banks, the CalPERS, the institutional investors, the pension funds. They are very interested in those companies who, over the long term, are going to lower risk for populations. And they're not doing it because this is jolly nice to do. They're doing it because they know the intimate link between societal risk in terms of health and long-term debt in this country, which is quite tightly tied. Anything you can do to lower long-term risk, both for the individual company and for the society, is something that a long-term investor is interested in. I could give you lots of smaller gimmicky companies out there. Obviously, it's easy to have a niche health product, and they're doing very well and so on. But let's think of the big corporates.
Sure. My name is Deborah Scott, and I actually have a question regarding prevention and health disparities. And as you know, that there are many areas where there's a lack of economic viability, where there's food deserts and individuals have lack of access to healthy foods and transportation. Do you believe that prevention can occur in these particular areas where there is low economic viability, whether prevention can occur in those areas without addressing some of these particular systemic issues? And then I also have a question going back to the financial matrix, and whether you believe that for these particular populations where it's known that there are huge health disparities, whether that may create, if there is a financial matrix, whether that may create a disincentive for employers to hire individuals who may be in these populations because of the huge disparity existing in these populations.
Really incredibly important questions. I mean, let me just start with the first general issue around can you address disparities without, I think what you're suggesting, addressing underlying social, economic, racist policies? And my answer is, of course, no, you can't. You can make some progress, but you obviously can't. You need to have all those sectors working together. And one of the proof points I've been interested in looking at recently has been, since I'm in the relative south, has been the extraordinary success of the hookworm eradication program of a century ago. And I was talking to colleagues at the Rockefeller Foundation. Many people are often unaware that it was one of the greatest, if not the greatest, public health success of the first half of the last century, the eradication of hookworm from this part of the world. And if you look at the county-specific hookworm rates of 1914, and then superimpose on them the obesity rates of 2014, you get quite a striking similarity. And I think what comes back to me is that you may have eradicated one set of risks, but you left the underlying conditions for any health and disease, which tends to concentrate more among the poor and the marginalized in any society, without addressing those underlying conditions. It was to be expected that you would see the highest levels of obesity, hypertension, and tobacco displacing what had previously been the infectious disease problems. So you eradicated the one set, but you didn't remove the underlying conditions. And I think that is about as powerful proof of what I think you're suggesting. I think when you get onto the issue of the role of an employer in a county with a high level of risk, and maybe Ali Muqtad would comment later, because I know he's shortly going to be releasing very compelling data that will show that the level of disparity by county in terms of risk. That is a huge issue that we are very interested in exploring. Some of the insurers we work with are very aware of the fact that, for example, in Alabama, Mississippi, Tennessee, the counties with the highest level of concentrated risk would not be a particularly desirable place to locate a major source of employment, because you'd be drawing from a population at great risk. I like to think of it the other way around. If you are an employer, what is your responsibility to the surrounding community, to the county health department, to the local health department? And one of the aspects of our report we emphasize is the importance of stronger linkage between the employer and the county and the local health department, not because it's a nice thing to do, again, but because it's in their material interest to work together to lower risk, to actually ensure that you've got the healthiest population and the healthiest family, which would have better impacts on productivity. So I think I haven't seen enough work done on that, and we're hoping to see how the work Ali's been done mapping the risks across the counties could be superimposed on top of it, the employment rates, the employers, and I think we'll then start getting a very interesting discussion around the counties where you're seeing the greatest risk and where you may have the greatest employment challenge. The last forum we held, or back one, was actually in Colorado, co-sponsored by the Denver Chamber of Commerce, to make exactly the opposite point. They made the point that from a business point of view, they're selling the state because of its low risk status and the health of its population. And they're seeing that the attraction for employees and people into the state is the very fact that they're able to have the environment where you've got the lowest levels of risks. I suspect the opposite is unfortunately happening in the counties with the worst risk. One last comment I'd say that, again, I think that under the Affordable Care Act, I have hopes that some of the provisions, particularly the community health center investments, which are at an all-time high after being neglected for decades, could very well be an opportunity to start blending private and public interests in a defined population served by the community health centers. And the whole notion of the community health center was to integrate prevention, care, treatment in a defined population. It may very well be that in those settings, which tend to be the poorest in the country, you'll see more innovation than you will in some of the middle-income or high-income parts of the country.
Well, I'd like to first, I think, address something that Betsy said, and we've talked about the partnerships, whether it's nonprofits or government, but we haven't really talked about the partnership we need to develop with the media. And the discussion about advertising, I mean, we need some sound bites that discuss and to make accessible the fact that childhood obesity is not necessarily the fault of the pediatrician, but the food desert and our other policies. I'm not as discouraged as she is, however, about the immovability of, for example, the Farm Bill, which did take a year to pass this year because of a lot of issues about it, and the fact that we do subsidize things for not maybe the benefit of the food consumer, but we do have the lowest number of cows in America in history. And beef, and the lowest margin of profit, that's because their corn is, instead of going to the mouth of the cow, it's going to the mouth of the automobile. But on the other hand, we do have more grass-fed beef now because they can't afford corn. So I think that there is an opportunity to get, instead of having the media basically attacking the healthcare, the quote-unquote healthcare system, if they could be helping to guide the dialogue that the average voter is interested in about the interaction of all these other things, I think that'd be very helpful. Lastly, I'd like to consider that we should just take back the word healthcare system, because America really has a pretty good medical care system, but it has a crummy healthcare system. We should take back and say, well, okay, we're going to do healthcare, and it involves educators, that involves politicians, that involves city planners, that involves the FDA. And you guys, you three guys, the hospitals, the device guys, and the drug guys, you can have medical care, but you can't call yourselves healthcare.
Thanks, Rhonda. And I think that's a great summary to this session as well, so I won't go on further. And thank Betsy as well. Coming from the media, I think she heard you, and I hope we're going to accelerate our discussion on the role of the media, which does shape and particularly frames the debate, and is the framing the debate that is the most important thing. Just to go back to 1964, my parents-in-law were in the US at the time, both smokers. The day after the report came out, they had no clue about the risk. They quit. Now, not everybody quit, but it just shows that there was a media story with a very clear message, resulted in change. We know that after the big World No Tobacco Days, we see a sudden jump in the desire for support and cessation and quitting. And that is a media event. The power of potentially, of actually using media is, I think, still in its infancy here. So thank you all, and thanks for the inputs, Betsy, and thank you to all in the audience. Let me hand over to Michael Eriksen for the panel. And I think we're going to bring out a table.
We've got 4 great panelists here today to continue this discussion with a particular focus on this public-private alignment in health promotion and chronic disease prevention. And we'll introduce each of them briefly to you. Many of you know them already. I'll introduce them briefly here. Is it possible to get the lights up a little more on the stage? We're not using slides, and they're kind of in the shadows here. We'll see, we'll work on it. Our 4 panelists here are Rhona Appelbaum, and Rhona is Vice President at the Coca-Cola Company. She's Vice President, Chief Science and Health Officer. She's been with the company for some time and is on a number of boards, scientific boards, health and medical boards and committees ranging from CDC to Harvard Medical School, and we're delighted to have Rhona with us today. Susan Dentzer is a senior policy advisor with the Robert Wood Johnson Foundation. She's based in Washington, where there is both a public affairs office and an office that keeps track on what's going on the Hill and in government, and has been a leader in communicating public health and health issues, both as the editor of Health Affairs for a number of years, as a correspondent and online presenter for public radio and for public broadcasting, member of the Institute of Medicine. Susan, thanks for joining us here today. Rodney Lynn is someone I work closely with here in Georgia, is on the faculty at Georgia State, is Associate Dean for Academic Affairs in the School of Public Health. Thank you for the lights. And I've been very active in state activities, particularly one that has served to promote physical activity in Georgia and has been a key linchpin in that for the last several years. And Gary Nelson is president of Healthcare Georgia, an extraordinarily important, again, Georgia, by its name, focused activity that has supported a wide range of very different kinds of both health promotion, disease prevention issues around the state. Prior to that, Gary was with the California Wellness Foundation, playing a similar role in health promotion, health education as a senior program manager. And before that was with the CDC in its Cancer Prevention and Control Division as Associate Director for Evaluation. So we have a wealth of experience and a difference of perspective in our 4 panelists, which I think will enrich our discussions. And with that, I think we'll run down the line here, starting, if it's okay with Susan, and we'll just go straight down along the way.
Thank you very much, Jeff, and good morning to all of you. As a commission member, I could speak on this topic from a variety of perspectives, but I'm actually going to speak from my perspective as Senior Policy Advisor to the Robert Wood Johnson Foundation, as Jeff said. The Robert Wood Johnson Foundation, as the nation's largest philanthropy focused on health and healthcare in the U.S., obviously has its fingerprints on a lot of the areas that we've already discussed this morning. But what we really are most focused on now is, and I would put it this way, we are paddling upstream. There are a lot of people with us in the boat, and we'd like more people to get in the boat with us. And when I say upstream, I mean that we are shifting our focus more and more to the upstream determinants of health, frequently, of course, referred to as the social determinants of health. Because of the baggage that the word social carries in America, we are starting to use the phrase culture of health, as Derek used earlier. But we are increasingly focused on these more fundamental determinants: education, incomes, environmental exposures, et cetera, and trying to reframe a lot of our work and also hopefully advocate for more reframing in the public sphere for attention on these issues. What does this mean vis-a-vis tying this together with chronic disease prevention, today's primary topic? As we look at the available evidence, we see things like the Adverse Childhood Experiences Study, which has been going on now for almost 20 years, 17,000 enrollees, joint study between the CDC and Kaiser Permanente, clearly showing on the basis of more than 50 scientific articles that have been published that adverse childhood experiences equate to chronic illness later in life. So if you are a child who has been exposed to psychological abuse, physical abuse, sexual abuse, what have you, very clear correlation with chronic disease later in life, even controlling for other factors. So we look at that, we put that together with the knowledge that we increasingly have about the role of so-called toxic stress. Again, adverse childhood events, issues related to growing up in extremely stressed, particularly poor environments. And we can see, and we know increasingly from some of the fundamental biological research that has been going on, that there's a very clear correlation between high levels of stress-related hormones, particularly cortisol, early in life, and the impact on disease later in life. So what does this tell us? This tells us that increasingly we need to think about the upstream investments that need to be made, not to eliminate these kinds of stressors, because that's probably a pipe dream, but at least if we can figure out a way to modulate them, moderate the effects of them. So one of the areas that has emerged for the foundation to focus on is early childhood education. What can we do to stimulate the effect of child development policies, early childhood education, again, as a way of finding children early enough in life, supporting them, and ideally supporting their parents to create healthier environments in the home, reducing the level of abuse that children are often exposed to. Now, how does this tie back to recommendations that the Vitality Commission might make? The word partnerships emerged earlier today, and we would want to underscore that. We see a role for philanthropy in particular to helping to bridge the gap and encourage the formation of partnerships across sectors. we think it would be extremely important for the commission recommendations to point out to employers that we very much salute, and in fact, we are funding some of the work of Ron Getzel and others to identify viable and important and evidence-based workplace interventions. But employers can't fix this by themselves. They cannot fix up a population that walks in the door potentially so damaged by a lifetime of exposure to toxic stress or what have you. We want to emphasize the importance of employers in this country and all sectors focusing on efforts to collaborate across sectors and look at these fundamental upstream determinants of health and figure out what their role can be in addressing these fundamental drivers of health status and not pretending that they don't have as equal a role in making a better, healthier America that starts in early childhood, if not before childhood. Because I neglected to say, of course, we also know that many diseases actually take root in the womb, if not preconception. And particularly we know this in the case of diabetes and exposure of infants in the womb, fetuses in the womb, to mothers who have, in the case of mothers who have diabetes. So what we want to basically come out of, we would love to see, or the commission report come out with a very strong set of recommendations for raising awareness about these fundamental drivers of health and creating a sense of ownership across sectors, and particularly among major employers in understanding the role of these drivers. Get in the boat with us and paddle upstream. We are all upstreamists now, is the slogan we hope to advance. So thank you.
Thank you.
So, good morning. We were asked to respond to a couple of the recommendations, one around strengthening the alignment between the public and private sector as it relates to messages around prevention, and second, stimulating markets and business models for healthier products. And whether it's the size of the problem or my bias towards it, because I do research in that area, I think obesity represents a really good opportunity to put our recommendations to action. When we think about the recommendations that the Vitality Institute has developed, I think there are signs of progress over the last 10 years as it relates to obesity prevention. A lot of challenges and opportunities remain in that area. But when you think about bringing the public and private sector together, I think there's been a lot of evidence of that can be a successful model around obesity prevention. Just to make a couple points, one is that I think leadership is vital as it relates to some of the things that Susan talked about and going upstream. And, often I think when we think about leaders, we're thinking about governors and the First Lady and large institutions and organizations. And with obesity, certainly that's been the case. I think Robert Wood Johnson Foundation in the early 2000s really started to put a lot of emphasis on this issue and be a catalyst. But there were state foundations like the Healthcare Georgia Foundation and others that were already focused on this as well. And so the investments that the foundation have made at a national level have really been a catalyst. But there's been a convergence of activities that were already happening at the local and state level. Some of the work that Jeff has done with the Institute of Medicine with support from RWJ, I think, is another example, and really provided a foundation to guide some of these efforts starting in 2005. And for me, I just think about sort of the chronology over the last 10 years or so on this issue, from sort of philanthropic investment and leadership of foundations and scientists, but also governors. I mean, it wasn't that long ago we were talking about Mike Huckabee in Arkansas when he was the governor there, and all the great things that were happening in Arkansas. And as a result of his efforts and CDC and others, the National Governors Association, the Council on State Governments, the National Council on State Legislatures, and others. The American Beverage Association has worked with the Clinton Foundation and American Heart Association to work on beverages in schools. So there has been a lot of progress, and much of it has included public and private partnership. More recently, we've seen the First Lady, Michelle Obama's efforts around Let's Move on one side, but on the other, the Partnership for a Healthier America, which is really focused on what can the private sector do to help advance efforts around obesity prevention. And then to talk more locally about some of the things that we've done here in Georgia through an initiative called Policy Leadership for Active Youth, which was funded by the Healthcare Georgia Foundation, really worked to take much of what was in the 2005 Institute of Medicine report about applying a socio-ecological model to the problem of obesity and figuring out how could we do that in this state? How could we bring together a statewide council of organizations to focus on this issue and try to implement policies that are at a minimum evidence informed where evidence is lacking. And through that, we've in Georgia passed the SHAPE Act, which is mandating fitness testing for all schools in the state. And, you know, again, that was another public-private effort in terms of implementing that, some of the evaluation work we've done around that. So these are really fruits of public-private partnerships. In every, district in the state, 97% of the schools as of 2012 were providing data. So leadership is vital. Partnership and collaboration is a theme that is here in this meeting, and I think that's true on all the initiatives that I just mentioned. One of the things that I think, and these are just food for thought based on some of our experiences here in the state. How do you advance partnership and collaboration, public and private? And some of our experiences, some of the work I've done on looking at coalitions as well suggests to me that, one, there have to be mutual interests and goals, and those need to be identified. So that's a starting point. You need a respected convener. You can't bring people together unless there's some degree of respect in the convening and in the process. There has to be some evidence to guide action. Again, on obesity, we don't always have the best evidence, and so we use the best available evidence. And then in terms of bad behavior, I think, this came up earlier. I think Michael made some comments. There can be bad behavior within these partnerships and these groups and collaboratives. And I think in our experience, you find ways to let the group rein in that bad behavior. Jeff and Michael have provided good leadership for play, and there were issues, but it wasn't Jeff or Michael's role to scold anyone, to bring out a stick and bring people back in line. There was a healthy discussion and debate in a way that the group reined in the bad behavior. We've all agreed that this is what we're working toward, and when groups or individuals step outside of that, there are consequences. And if you have policymakers at the table, there are regulations that can be put in place. You could be excluded from the group. There's funding implications. There are all sorts of ways to rein in bad behavior, and I think we need to think about that. The last point I'll make is just about measurement and evaluation, accountability. You can't hold organizations accountable. You can't hold programs accountable if there's no measurement and evaluation. And so as we make investments, as we partner to implement new initiatives, there also have to be measures so that we can assess how we're doing, make adjustments, and where we're not being effective, make wholesale changes. So those are comments.
So I, too, would like to address the public-private partnership piece of this equation from the philanthropic perspective, one that some folks call the third sector. And you've heard that I represent a foundation, a statewide foundation, one that its mission is directed to the health of all Georgians, but specifically and overwhelmingly to access, cost, and quality issues for underserved populations in our state with a lens on achieving greater health equity. Over our 12 years of funding in this area and a modest $50 million in investments, we've had the fortune of identifying some fairly effective partnerships, including the one you just heard from, Play. And so I would like to identify them briefly, but identify my top 10 characteristics, if you will, of those partnerships and what made them effective from our perspective. One that stands out for me, in addition to Play, is the Chatham County Safety Net Partnership. It's one in which some 40 organizations in this state, in Savannah, have come together, hospitals, public health, community health centers, community clinics, city and county government officials, and business, to pool funds and to align those funds with the performance of the safety net. And I think that's a rather remarkable feat, and one in which it's clearly making a difference. The safety net, by the way, is addressing overwhelmingly some 50 to 75% of their entire clientele are presenting with chronic disease. Another one, early on, our experience in local smoking ordinances and tobacco control was another effective public-private partnership. We were involved in a public-private partnership that helped create a standalone Department of Public Health in the state. And I'd like to speak to an element of that as well. But my observations quickly are these. In every one of these cases, the public-private partnership embraced the notion that results matter, that there was a commitment to continuous improvement and evaluation. Secondly, there was a recognition that a relationship exists between the health of a community and the economic vitality of the community. Many of you know that there are county-by-county health rankings across the country. In our state, there's no surprise that the 5 healthiest counties in this state also score the highest on measures of economic vitality. That message seems to be lost in our efforts to address policy and implement programs around the state. Third, these partnerships embrace thought leadership that's neutral, that's nonpartisan. And I think that was terribly important in particularly the Chatham County and the tobacco work. The work is always bottom up versus top to down, or driven from the top. Fifth, they seem to align resources with performance of its members, much like the Chatham County effort. There's an orientation to population health in their work. They get it. They understand it. It's not just about the health of an individual, but the health of the entire population. What I also appreciated about these partnerships is that they anticipate scale and sustainability. They're thinking about these issues on the front end, not on the back end. So consequently, fortunately, we don't have tombstones, but we still have live, active, functioning public-private partnerships. They embrace, they have a social justice mission. They have a health equity lens. To the questions earlier about the social determinants of health and health disparities, clearly these populations or these partnerships understood that those most adversely affected, those with unequal access or unequal outcomes, needed to be represented at the table in these partnerships. They thought not only of programs, but they also thought in terms of policies and systems change. They knew it wasn't just enough to deliver a well evidence-based program, but there needed to be policies in support of those programs, and that there needed to be a systems change element to sustain it. And lastly, I think most of these partnerships had discipline. They had the ability to say no to opportunities that caused them to stray from what was most important in their communities. The last comment I would offer is from a philanthropic perspective, and that is, I think historically in philanthropy, we've embraced this notion that public-private partnerships naturally exist, and that I don't know that we have really taken on the task of building a culture of public-private partnerships in order to achieve what we've set out to through our funding. So those are my comments. Thank you.
I have to start by saying that I agree with all the panelists. I mean, it's been wonderful. And we have a saying at Coca-Cola that when you find a good message, the most important thing to do is echo and amplify that, harvest and reharvest. And I am humbled to hear in terms of the value and the importance that all of these individuals, from the beginning to now, and hopefully throughout today's meetings, the emphasis given public-private partnerships and public-private collaborations. Coca-Cola cannot do very much in the absence of partnerships. I'm currently in the Office of Sustainability, as Jeff mentioned, in terms of serving as the Chief Science and Health Officer. Within our sustainability framework, we have 3 areas, what we like to call 3 pillars. It's about the individual, gets to the workforce, it's about the community, and it's about the environment. And yes, we are a very good marketing company, so we keep things in 3s, and we like alliteration, so it's about what we call me, we, and the world, and it's about well-being, women, and water. And the reason is because we find that to be, if you will, the tripartite for health and wellness and well-being in terms of how we're looking at that. In each one of those pillars, whether it's well-being, and well-being we define very holistically, from physical, we heard that today in terms of the WHO definition, physical, mental, and emotional, but we also add financial. And when we're looking at our workforce in particular, because the stresses associated with financial status, I'm not saying status in terms of, the Joneses. I'm talking about being able to make sure that you have enough food on the table, that you're able to give your kids things that you didn't, you're able to send them to the schools that they need to do, or just participate in having fun. So financial for us in terms of looking at that as a key core item in terms of how we define well-being is very important. Women, of course, I don't have to mention, they are the pillar in terms of the family unit, however you define family, but also the community. And we know from our 5x20 program that when we empower women to be entrepreneurs, economically independent, the first thing that she makes sure is that her family, her children are healthier. And then because we are gatherers, when we drop from the trees, you guys are hunters, but because we are gatherers, we bring in our sisters and ensure, if you will, the health of the community. And finally, even though I said water, because it's the 3 W's, doesn't mean that we forget about climate. Obviously, sustainable agriculture is very, very important for us. But water, second only to oxygen in terms of the health of any community. We focus in on the community as a whole because that's where we operate. Even though we're a global company, we operate locally. And the health of our business is intimately tied to the health of that community. And what we have found over the soon-to-be 128 years that we've been in business is the fact that we can do well by doing good. But we also have learned, and this goes back, to our forefathers in terms of what we did, Mr. Pemberton did, what we did in terms of CDC, that we can't do it alone. We have to do it within the construct of partnerships, within the construct of collaborations, within the construct of relationships. I could go on and echo all the points that, again, the panel have already mentioned, as well as the comments that Derek had mentioned in terms of what's absolutely vital. In today's world, everything's transparent. There are no secrets. There is one. However, I don't know it, so I'm not even going to bother to talk about it. But, it's absolutely important. If we say we're going to do something, yes, we want to be judged by that promise, what our reputation is, but we also have to trust but verify. So the points that are being made today as it relates to the independent evaluation of commitments is absolutely key. And when we do work, whether it's with our partners, the World Wildlife Fund, whether it's with the American Academy of Pediatrics or others, it's to make sure that what we say we actually do. And what you do needs to be measured. Because how are you going to know if you're going to be achieving that goal if you're not measuring it? And you can't just measure it by yourself. You have to do so with third parties. When we're looking at health, obviously that includes obesity. We look at it from the perspective as the largest, beverage company in the world, non-alcohol, ready-to-drink beverage company in the world. We look at it from 2 angles. It's about what we call it active, healthy living. That's about that balanced sensible diet combined with regular physical activity. We look at it from the perspective of healthy energy balance. It's not only about physical activity and as we say, sitting less, moving more, but it's also making sure that people have the necessary ability to construct that healthy diet. But we also realize that in the absence of physical activity, people are not going to be able to maximize their health. So we look at it from two approaches. But whether we're looking at it from the diet perspective or we're looking at it from the physical activity perspective, there's nothing that we can do in the absence of working together. Muhtar Kent, our chairman and CEO, calls it the golden triangle. Business is only one side. Obviously, the government is the other, but the foundation is civil society. We can't do anything in the absence of including, whether it's the foundations, whether it's the academics, whether it's, everything that doesn't fit into the business or the government as a whole in terms of working together. And when you look at that construct, I don't think there's anything stronger than when you have that type of unity. We sometimes start with only two, but then we encourage and do whatever we can to bring in more. And Derek mentioned, if you will, the Healthy Weight Commitment Foundation, which started with business, with Pepsi and Safeway way back when, but now has broadened in terms of I'll call it a campaign in terms of what more that we can do. Derek mentioned the fact that 6.4 trillion calories have been taken out of the marketplace here in the United States, because we know we have to make a difference in terms of making it easier for people to help in that, what we call that healthy energy balance, to make sure that they're not over-consuming to excess, that they're getting all their essential nutrients, that they're also being physically active and they're having fun. We think that's very important as well, that it can't always be a chore. And what we can do in terms of making that happen, in terms of working, across all sectors, is absolutely essential. So, one of the points that was made today, is sometimes when I read a bad headline, you want to say, oh my gosh, the media. But we all have a role in making sure that we provide that 360 approach in terms of making sure those messages are getting to the consumer and getting to the public in order to motivate change and catalyze them to making a difference for themselves and their family in terms of that path to maximizing their health. So with that, I'll end, and I look forward to the Q&As. Thank you.
Great. We're going to start off the questions with George Landers from Georgia State to get the questions going.
Microphones. Again, Glenn Landers with the Georgia Health Policy Center here at Georgia State University. So I was asked to think about or listen to this panel as they were talking about public-private alignment around prevention. So I jotted down some keywords from each of you, and I'd just like to repeat them because they created a theme for me as I was listening to them. So I heard upstream determinants, cross-sectoral collaboration, neutral leadership, accountability, results, scale, sustainability, well-being, and community. And when I hear those things, and I think about public-private alignment, I also think about collective impact, because a lot of foundations particularly are trying to get multiple partners around a common agenda. And I think we even heard at the beginning that there seems to be a common agenda missing around prevention. So, and in fact, I'm working with the Atlanta Regional Collaborative for Health Improvement, and I can tell you, getting folks around a common agenda, even something as benevolent as improved health, is very difficult. So this may be a very challenging question, but I would ask each of you to sort of weigh in on what is the key ingredient that we need to get to a common agenda around prevention, thinking about local, state, and national levels.
Well, I would just like to pick up on Rhona's comment. I think it was, if you hear a good message, echo it and amplify it. And I think that we can start by pulling out the clear nuggets of knowledge that we already have. And I second Derek's, the Commission's wonderfully important point that we lack evidence on a lot of things. That's true, but we also have evidence on a lot of other things. And to the degree that we are just increasingly pulling out the nuggets of knowledge that we already have, the evidence that we already have about whether it's about the health status of the population, whether it's about the role of toxic stress, whether it's about the adverse childhood experiences study, or 10,000 other things I could mention, and putting this out there because it is frankly astounding how little attention is paid to what we already know. And so if we can at least take the first step of crystallizing for people in very easy and accessible and understandable ways what these various linkages are that we are already well aware of with respect to the inputs into health and what we need to do to maximize health. Let's start there and make those as clear and graspable as possible. A wonderful, wonderful book that was written about 10 years ago was Made to Stick by the Heath brothers, and it talks about what sticks with people. Let us use that approach to figure out how we make these fundamental messages stick, because it's only by making those things stick with people that I think you start to get an awareness around the need for cross-platform collaboration and, importantly, action.
I would add, I mean, having a message you can sell is important, but I think it's also important to tailor your message because the things that benefit industry versus a community versus a school, framing those benefits around engagement in the effort, I think there has to be thought given to how to do that effectively. And who's delivering the message, I think, is also important. It goes back to the issue of leadership that I was focusing on earlier. The message coming from one person, agency, or entity versus another can make a difference. I mean, even when we think about policymakers, the question is, what is it that they need to hear? Who do they need to hear it from? So I think this is true when you're trying to build partnerships and sort of broad collaboration as well.
At the risk of sounding like it's a magic bullet, I still believe that it's about a common set of metrics with financial resources aligned with them.
I've got some questions. Others can grab the mic and I'll stop, but just to pursue a couple of things here. Rhona, you've seen Derek's list of the commission reports. How do those strike you from the perspective of your own major global corporation? Are those the things he mentioned this morning, the various target areas, the priority areas that health should be embraced as a core value in society, a strategic imperative across all sectors, and then the recommendations, align public and private sectors, what we're talking about here, encourage employers to integrate metrics on workforce health into financial reports. Just to even take that one alone, is that likely to happen with the Coke board in the next 5 or 10 years, integrating health metrics into financial reports? It often doesn't happen in medical centers, I'll tell you.
Well, the reason I raise the issue of what we're doing right now with a focus on our workforce and raising the fact that we're looking at wellness and well-being very holistically is the fact that we want to be able to measure it. At this time, in terms of my role, I can't tell you what will be part and parcel of the financial reports. But because we know, and the data are pretty strong, that the healthier the workforce, the more productive it is. If people are healthier, less stressed, the better business you have in a number of ways. I can't imagine it not being. One of the other things, Jeff, that we're very much involved in is with the Bipartisan Policy Center, working as one of a number of businesses right now. We're hoping to expand it with a call to action on the CEO Council for Health and Innovation. And one of the things that I really liked about, I'm going to call it, it's pretty, Derek, I hope this doesn't become, if you will, the code for this, but it's almost like Derek's manifesto is what these 5 points are. So I hope Vitality doesn't shoot me or anything like that. But I love the focus on health. I love the focus on health because there's a tendency to, focus in on something that raises, if you will, negatives, whether it's obesity and making people feel badly, whether it's the fact that, poor, and people feeling poor versus, having all the other opportunities. I love the fact that we're focusing on health, but not ignoring the determinants that underpin that. The cultural, what did you mention, Susan? I loved it.
The culture of health.
In terms of, not using, if you will, negative words or euphemisms to try to avoid, but focusing on what health needs to be. So Jeff, it's a long answer to your short question. I thought in terms of all the ones from number 1, in terms of aligning the public and private sectors, which, you can't align if you're not, if you will, beginning to develop a relationship or a collaboration or at some point in time, hopefully a partnership. Or I love the point, Moderator, in terms of alignment. So now I have PPPs, PPCs, and now I have PPAs. So this is great. I have another acronym. Encouraging the employers to do what they need to do. Absolutely. When we're looking at trust, which is so totally important for a company like Coca-Cola or any company. You could talk about brand love. I'm not a marketer, I'm a scientist. You could talk about brand love, and they could love your brand, but if they don't trust you, they can love you, but they may not trust you. That can impact your business severely. With that said, with that point of trust, what is the number 1 attribute for trust? It's motivation. What is motivating you? Absolutely very, very important. And the thing is, if you're not motivated by doing right by your family, and in a corporate world, that's our employees. If you're not doing right by your employees, your family, how do I know you're going to do right by me and my family? So these are all things that are so aligned and so interconnected that we have to continue to focus in on those. The other one, shift investments to fund preventive science. I'm proud of the work that we continue to do, whether it's through the American Beverage Association, Rodney, as you mentioned, or ourselves in terms of trying to find the factors that are underpinning the pandemic of childhood obesity in terms of a study that we're doing currently with Pennington. And when I say what we're doing a study, what Coca-Cola means when they do studies is that we ask the question, we provide the sponsorship, and then we just step back. And that's whether we're doing it with a university or through working with the CDC Foundation to increase the capability and the capacity for lower and middle income countries to deal with NCDs, as well as increasing health across the board. And the last one, in terms of stimulating markets and business models to develop and deliver healthier products, absolutely. And through partnerships, I'm not trying to be humble on behalf of the Coca-Cola Company, but if you think we have all the answers, oh please, we don't. And the way we find answers and the way we begin to change our point of view and the way we begin to focus on different areas that need focusing on is when we have those partnerships. Now, are we always going to agree? I always try to say with partners as well as collaborators, it's almost like a marriage. And Lord knows I don't believe or agree with my husband 100%. Doesn't mean I don't love him and trust him, but it's that same type of area in terms of what is that sweet spot that you want to work on and help us get there. Help us get there. And what can we do with our collective genius and our assets in terms of helping collectively do what we need to do to maximize health?
Thank
Good
you.
morning. I'm Nazira Dawood. I'm the Health Promotion Program Manager at Fulton County. Thank you, Dr. Eriksen, for the invite and the Vitality Institute for holding this panel discussion. I have two questions. Number one, how important is the political will in building these public-private partnerships? Because as a Health Promotion Program Manager, we take up several initiatives and get the community pumped up and build coalitions. But then I always see the power, unless the political will is there, it doesn't really get anywhere. And the second question was, with limited resources in local public health departments, how do you see us moving forward? Do we just sit back and say, hey, wait, we'll wait for the money? Or do we say, let's do something, let's build something with the community, and the money will come in? Thank you.
Let's have one person take it and maybe do a very brief answer so we can get in a few more before we close up. We're going to try to catch up a little bit with the time lag. So first one is political will. Rodney, you're natural for that.
I'm happy to take it. I think, Nazira, the issue of political will, trying to change policy is a process that has a lot of steps to it. And, having the partners at the table, the agencies and organizations is one, but you have to have the grassroots. I don't know if it's Gary mentioned bottom-up efforts. And so it can't be just the organizations at the table. Elected officials respond to their constituents. And if there is a threat that they may be asked not reelected or removed from office, that is a motivating factor for them. So I think as people seek office, as they seek reelection, it's important that if you have a coalition, that coalition includes both agencies, organizations on the public and private side, as well as residents, representatives of residents, whether that's neighborhood associations, civic groups, and so on, that the elected officials will be responsive to. And you have to know what are the things that are motivating the elected officials, who do they listen to, and those are triggers or levers that you can pull to get to them, if you will.
And the second question?
Was limited resources, you wanted me to take that, or does somebody else want to?
Well, you deal with limited resources. Go ahead.
All right. I think this is a challenge, and I think when we look nationally at funding for public health and prevention, all of us in the room would want to see more funding. This maybe relates to the first question, and that's how resources are allocated. In terms of the prevention fund and resources that have come through CDC and will continue to come from CDC and HHS. Those are resources that local health departments can apply for. We recently worked on a grant together, Fulton County Health Department. So I think that's an ongoing challenge, but it's also speaks to the need for partnership. The health department can't do it alone. You have universities in your backyard. There are other community-based organizations, the Cancer Society. We're fortunate to have CDC here. So there are a lot of resources out there, and we would all like to see more dedicated to local health departments. But I think we have to work with to increase the political will, as well as how do we leverage the resources that are already out there.
Two quick questions for our two other panelists. Gary, you've had intense experience in trying to promote health in California and in Georgia. How would you compare the pluses and minuses in both states for promoting a healthier society, a culture of health?
Again, it's an unfair generalization to make, but I would say that there's a different way of doing business where communities are very much the center of the universe in terms of designing, implementing, evaluating programs. So collaboration and partnerships are a natural outgrowth of that work. The other thing I would note is that the resources for the prevention science always seems to be there. And rarely does the state find itself in the position of backing into a position of political will and personal choice. So there seems to be a momentum. There seems to be an ability to build and sustain momentum. But I didn't want this conversation to go without that comment, because I do think, back to the public health comment, the absence of public health resources is trumped by, in some cases, a retreat to personal choice. If we don't have resources, then it's a personal choice issue. So I hope that the issue of messaging comes back to this the other panel.
Thanks, Gary. And Susan, just to wrap up, so in 15 or 20 years, what will this culture of health look like in Georgia? Does it look like where we are now? Will it look different if we have this meeting again in 20 years and Derek and the Vitality Institute are really successful in making all this happen? What are we going to be looking at?
You would have a world in which all the various sectors and stakeholders realize that health is a function of many things, but it is mainly a function of having a world in which incomes are higher for many Americans than they are now. Education starts sooner and creates more stable environments in the home. As much as anything, where education persists over the course of a lifetime, where environmental exposures are addressed and reduced, and where everybody understands that we're all in this together, and that the entire society doesn't stay healthy if some segments of our society are particularly unhealthy. And so it's a world, I hope, where people don't just sing Kumbaya about how we all have our interests
Don't look at me, I'm not going to
way.
sing Kumbaya.
But rather one that understands that we need to make these upstream investments and that they will have long-term payoffs. And sometimes they will be long-term. But if we don't start today, we're not going to see the payoffs 20 years down the line. And if we don't want to be just a country where there's only one economic activity going on, people getting or giving health care, because that's the trend line that we're on. If we would like to be a society where we're engaged in many, many other productive activities across many other sectors, and not to mention have a fiscally viable government and society along the way, then we have to start by making these investments and joining hands across sectors to accomplish them.
Thank you. Good note to end on. Thank the panelists, and we'll be back in 5 minutes, 6 minutes, 8 minutes.
Well, before you leave, I'd like to call Rodney up, who is going to model us doing some activity before we go out to eat there. So no coffee until we've had Rodney.
Sorry, I'll make it quick. My name is Brittany Balsa. I'm a personal trainer down at Georgia State program down there. I trained Ellie right here, so if you want to know about that experience, ask her. I just really want to take a few minutes. Part of public health, one of the major things that we are responsible for is being a role model to people around us. As a personal trainer, it's very individualistic, so we're going to do a little exercise as I ask you a question.
Model No, it doesn't require any physical activity, just standing up and sitting back down. So I'm just going to ask you guys a few questions, and then if you agree, stand up, just kind of follow the flow with me, okay? So first thing I want to ask you is if you would stand up, if you would really enjoy this warm weather to pick back up again for us. Thank you. That's kind of what I expected. Oh, I was about to say. Okay. Well, we got a few that like this cold weather. Okay, you can sit back down, I just got back from Vegas, so whew, it was nice out there. Second question I want to ask you, stand up if you worked out this morning. Did some form of physical activity this morning. I know it's a little chilly outside, so that gets difficult. Halfway? Okay. Go ahead, sit back down. Stand up if you ate breakfast this morning. Oh, awesome. Okay. Everybody's alert and thinking well. Okay, go ahead and sit back down. So obviously these are questions that tie right into our health and our physical well-being. So now I'm going to ask, stand up if you work out approximately 2 to 3 times a week. Any kind of working out.
Or more.
Awesome.
Or more.
Okay, go and sit back down. That's pretty good. Good job, guys. Okay, stand up. What was another one? Let's see. Stand up if you take healthier forms of transportation to and from work. Biking, walking, public transportation counts, I guess.
How about sometimes?
This is Atlanta.
Awesome, okay. Everybody drives. I drive too. It's okay. Stand up if you spend some part of your weekend or free time outside, maybe up in the mountains. Outside, walking through Piedmont Park. Maybe. Okay, go ahead and sit back down. So like I said, I didn't want to take much more of your time, but get in the mindset of we are role models, whether you're a personal trainer way down here or, way up there. We are always going to be a role model. So the healthier you live, the better off these initiatives and these goals will go in the long run. Okay? Thank you very much for your time.
Well, good morning. We're about to start the second panel for this morning's activities, and I'm confident that this panel will be as enlightening and informative as the first panel was, which I thought was excellent. I'm really that this event is being widely streamed and viewed because the people that we have here are exceptional in terms of their involvement and leadership in chronic disease prevention. Hopefully this will really help inform the Commission in terms of their recommendations that come up from it, because I really think this process can be a very pivotal one to transform how we look at prevention and chronic disease specifically, and that this meeting, even though it's not extremely well attended, can be a really important part of advancing this agenda. So I'm very optimistic about that. This panel is going to be focused on looking at the research that undergirds prevention science and the importance of really understanding and communicating what we know about what will make a difference. As I was reflecting on this morning in the presentation and the discussion on social determinants and culture of health, I realize it's upstream in many ways. It's upstream not only in terms of social determinants, but it's upstream in terms of swimming upstream, because it's often a tough sell to get people to look at the distal causes of disease, and that we collectively tend to be more comfortable with looking at the proximal causes. We look at the behavior and the outcome, and what we need to do is expand that view, and that view needs to be expanded through research. I thought I knew everything I needed to know about chronic disease science and research, but then I read the papers and I realize I really don't know very much at all. I don't know about the role of fat in heart disease. I don't know about the role of nicotine and tobacco and lung cancer. I don't know about how often I should get a mammogram. I don't know about PSA testing. All of the things we think are givens around chronic disease prevention tend to be confusing, increasingly confusing. So the science is extremely important. So our panel today will both talk about the importance of underlying our efforts around chronic disease prevention in terms of research, in terms of science, and how that information can be used, with, I hope, a particular emphasis on some of the areas that we don't spend as much time on, looking at social determinants and also looking at the health in all concept. And we're very pleased to have some people who can speak to this exceptionally well. So let me introduce the speakers. We'll hear first from Ursula Bauer. Ursula is the director of the National Center for Chronic Disease Prevention and Health Promotion. The only reason I can say that without looking at my notes is I used to work there, and I was fondly remember it. Ursula has been the center director for the last 4 years and joined CDC from the New York State Health Department. She has her degrees from Yale and Columbia and is providing leadership on the effort around winnable battles in public health, and many of them have to do with chronic disease, health promotion, and reproductive health. We have next Paul Morris. Paul is director of the Atlanta Beltline. Derek referred to it earlier. I can't remember how he referred to what term he used, but I think you'll get a chance to learn about the Beltline, which is one of the most spectacular undertakings in the nation that's going on right now that many people in Atlanta don't fully understand. And Paul will give you a sense of how physical activity, active living, transportation, and community come together in this project, and we're really excited about that. Paul is new to Atlanta, joined us from Charlotte, North Carolina, probably just a few months ago. So we're very excited about Paul being here. Next we have John Seffrin, and John is probably a person who really needs no introduction. John is a global figure, a leader in cancer prevention and control. He's been the executive, the CEO of the American Cancer Society for over 20 years now. And we were discussing this. He may be the longest serving CEO of a nonprofit in history. Certainly the longest serving CEO of the largest nonprofit in history. The American Cancer Society is really a unique organization globally in terms of its mission and its effectiveness, and in many ways operates like a university with its own intramural research program and an extramural research program. And again, located in Atlanta and making part of why this meeting is so special. Then we have Rob Schreiner. Rob is a physician, and he's the executive medical director of the Kaiser Permanente medical group. It's one of the largest healthcare providers in this region with over 250,000 members. Rob is particularly interested in continuous quality improvement and cost issues around healthcare delivery. And as you know, Kaiser, of any of the health plans, Kaiser is the one I think about most when I think about health promotion and chronic disease prevention. And their Thrive campaign, I think, is exemplary in terms of trying to get a message out to the public regarding the importance of wellness and taking care of oneself. We'll hear from each of the panelists for a couple of minutes, and then we'll have our, I don't know if it's a thought starter, but we're very fortunate to have Rhona, who is a part of the Vitality Commission. She has had a career in the Army, responsible for advancing physical and psychological health of our U.S. military from 2008 to 2012. And we'll be able to comment about the importance of health, not only for its own sake, but also in the context of readiness to serve and how important readiness is. And this relates back to our earlier issue, is sometimes look at what is the common ground. Why are people interested in our issue of public health and chronic disease prevention, and how does it resonate for other, whether it's the private sector, corporations, or the military, in terms of serving their objective as well, looking at that common denominator. And so she'll come in at the end and ask some questions of the panel, as well as we'll open it up to you all. So with that as an introduction, I will stop and ask Ursula to kick us off.
Great. Well, thanks so much. It's been an exciting morning, and I'm delighted to be here. So the Centers for Disease Control and Prevention is the nation's prevention agency, even though in our daily parlance we often forget about the prevention part of the name and just say CDC or Centers for Disease Control. But we are the nation's prevention agency, and our main role in prevention is to disseminate out and try to scale up the strategies that we know work to, in my case, prevent chronic disease and promote health. We have less of an investment in actually developing the prevention science, but that too, is a critical part of our contribution. And we have a number of ways to do that, which we were asked to talk about today. An old-fashioned method is observation. And when we confront a public health problem, years ago it was tobacco use, we don't quite know how to promote smoking cessation, how to prevent initiation. We look at places where that's been done, where creative interventions have been tried, not evidence-based at the time because they're new. And as we find areas of the country where rates are coming down or the rise is leveling off, we do a deep dive to see what's happening there. And that's how best practices emerge, that then we can disseminate more widely and study more formally and actually begin to build the evidence base. We have an endeavor that the agency supports called the Guide to Community Preventive Services, which looks at the research, the literature, the practice, and really does a very formal and in-depth assessment and review of that literature, and can synthesize that and come up with recommendations for public health practice. And we have a range of recommendations related to tobacco control, to alcohol use prevention, to diabetes management, and on and on and on. And those recommendations are generally rock solid, and really our goal is to put them into practice widely. We mentioned earlier, I think Derek mentioned the prevention research centers, and that's a formal way to develop new ideas, actually put them into practice, test them, evaluate them rigorously, and then begin that process of building the evidence for how those work in practice. So these are some ways that we contribute to the prevention science. I will say the science follows the practice generally by a good decade or more. There's a lot of innovation as we confront public health problems and try to figure out how to solve them. And it's really by experimenting in areas across the country, trying things out, evaluating them, and seeing that they work, and then building that science. Even when we have the science base, though, we seem to struggle with that political will in terms of actually bringing those proven interventions to scale and actually having an impact.
Thank you. Paul.
I'll start by saying, of all the panelists today, I'm probably the one most centrally focused on day-to-day practical applications of all of the incredible research and analysis that's going on, whether it's through federal agencies or institutions. And so much of what we are focused on at the Atlanta Beltline is focused on the built and natural environment, what we can do to, as many people characterize it, transform the social construct of this city and this region is made possible through largely, initially the private sector, through philanthropy, and then the private sector development community, followed by the public sector. So it is really, to some of the earlier conversations around the Commission's recommendations and findings, very much about the marketplace driving a lot of our discussions about what constitutes healthy living, active living, mobility, transportation mobility, mobility independence versus dependence for a lot of people, and also recognizing that a major infrastructure project, and for those of you who are not actively engaged with or familiar with the Atlanta Beltline, it is by definition the largest redevelopment project in the city's history, and currently the largest redevelopment initiative in the United States, is by its nature designed to transform the city, and not just the landscape of the city, but to inject into the culture of the city an understanding of how investment in the public realm actually changes the course of the economy. Which brings me to kind of a global reference point that's important to keep in mind, which is, in a very practical way, we recognize that when we're talking about public health, when we're talking about healthy living, healthy environment, we recognize that most of our strategies are defined by culture and the economy, not the other way around, right? The strategy doesn't alter or drive the culture of the economy. The economy and the culture of our city and our region are defining and driving our strategies. We do what we can on the front end to create a lot of framing instruments that give us guidance about the scope of the infrastructure investments that we need to make. We have a 22-mile loop of historically utilized and now largely abandoned railroads that were called Beltlines that were never connected and are now being systematically connected into a loop that circumnavigates the historic downtown of Atlanta and brings together, for the first time, all 45 historic neighborhoods, largely that were, by design, separated over time. And we can have a much larger conversation about the social implications of the statement I just made. Having said that, what we find as we go about all of our improvements and our decisions is that in a program of almost $5 billion, largely unfunded, that we're advancing, doing the right thing isn't enough. We actually are constantly getting challenged to say, are we actually improving the mobility, the capacity of the community to engage in their community, to live and have better nutrition that is healthy in their lives? Are we, frankly, improving the environment? If you think about it, 22 miles of historic railroad are largely contaminated real estate. So we're literally having to clean up 1,000 acres and put back into environmentally healthy and productive use an incredibly large part of the city. Our influence goes beyond the corridor. It includes almost a half mile of either direct influence or oversight of on either side of it, constituting about 20% of the city of Atlanta. So in a weird sort of way, as a private entity that is not a governmental organization, we are at the same time almost embodying both the public and the private side of this partnership. And our constituents are largely the community at large. This is arguably the largest grassroots undertaking in the history of the United States, largely driven by residents of neighborhoods who had great interest and I would go so far as to say command of the and awareness of the challenges facing themselves. And it was driven by health. It was a recognition that the city was not healthy. The landscape of the city was largely concrete and asphalt. There was not really the kind of mobility that many of them hoped for. And as a result of that, it impacted their ability to lift up, to improve their status in life, to be able to actually have access to healthier living, more active mobility, and healthier nutrition. And so as we build out our infrastructure, which is largely thought about as a transportation project with 22 miles of rail transportation, 33 miles of trails, 1,300 acres of new parkland, we're also realizing, almost kind of as we do it, that this is probably the largest economic and social experiment going on in the country. Because the community is teaching us as we grow how we need to reform and advance our program. And as a part of that, we've expanded to include 46 miles of new streets or rebuilt streets. So we're actually putting bike lanes and sidewalks into neighborhoods that never had them. It might not seem significant, but in a largely vulnerable population, which these railroad corridors you can start to think about were the kind of the repositories of underprivileged and often segregated populations. They, while being the most vulnerable, are also the greatest beneficiaries. And those vulnerabilities, with the help of Georgia State and others, we've actually now documented. So we know where the health hotspots are. And while we build all the infrastructure and make these adjustments to our investments, we're also recognizing that that isn't enough. What we're realizing is that, and this is something I think many of us know intuitively, that people are not, all of us by our nature, are not naturally inclined to get out and exercise and live actively. And in populations that have largely been compromised over the years, it in fact has not been a part of their culture. So we've embarked upon a whole other dimension for the Atlanta Beltline, which is what we call our social programs, where we're actually working with a lot of these neighborhoods. We're bringing nutritional discussions into the classrooms of the schools, into the neighborhood discussions, into the churches. Many communities have actually not seen most of the vegetables and fruits that a lot of people get on their grocery store shelves because the grocery stores that, if they have access to, don't provide them, never have. But more importantly, we're realizing this is an intergenerational discussion, multi-generational discussion. And so a lot of our efforts to engage the community in our exercise programs, in our tours of the Beltline, in our outreach about healthy living and nutrition, we're actually having situations where mothers, daughters, and grandmothers are participating together in our exercise routines, where dads are with their kids learning to ride a bike for the first time. Not because they didn't want to, but because in many of our most compact, largest cities, it wasn't an option, either because the infrastructure was not there, their culture did not contribute to it, or, and this is really the hidden problem in a lot of the work that we do, it wasn't a safe environment, regardless of whether it was a healthy environment. So our community of partners is ever expanding. We probably have 50,000 today, and many of those are individuals, volunteers, donors, but a lot of them are institutions. And so we're constantly broadening to include organizations like the Atlanta Police Department as a partner to help improve the health and safety of our neighborhoods in order to make it possible for families to actually be out walking and biking. On the other end of it, we realize that while there are entities of advocacy around a lot of the things we are talking about today, there actually aren't a lot of opportunities for implementation. So we've embarked upon kind of a systematic prioritization and execution plan of targeting certain things that we can do. And one of the most notable that has emerged in the last 6 to 12 months was the establishment of what we call the Urban Agricultural Farming Program, where around the Atlanta Beltline, in that 15,000 acres that we're working with, we will actually be with partners across the state developing commercial entrepreneurial farming enterprises that will literally be, through our efforts to clean up and repurpose land, put it back into healthy production, and actually make available to largely food desert communities organically grown fruit and vegetables that they can buy on the spot, and how they get there is through walking and biking to that destination. So there's a lot of impact that we can have, and it would sound like it is indirect because it doesn't appear to be targeted or prescribed, but we recognize that a lot of what we do in the context of application is really back to this issue of social experimentation, tapping into people's desires and natural tendencies and abilities. So we see ourselves often creating opportunity as opposed to telling people what to do. To that end, we think we're making progress because in the first major segment of the Atlanta Beltline completed and underway for about a year, we have now just broken 1 million visitors, which puts it on the par from an economic standpoint with the Georgia Aquarium and the World of Coke. Never would have anyone thought of public infrastructure as a focal point for that. But the ultimate testimony to our success is how it is transforming economic development. And so now we have housing, office developers, healthcare agencies, most recently Athena Healthcare, who was leaving Georgia and was out in Alpharetta, is now moving to the Atlanta Beltline because their young employees wanted to be able to live and work along the Atlanta Beltline. And the executives had thought their employees wanted to be out in the suburbs. And a large part of that is now influencing even our own investment decisions on how we make sure that we have influence on and are supporting the needs of the neighborhoods in order to create more density, more affordability of housing, so that we actually are lifting up people's lives in ways that actually give them access to and the ability to be more healthy. So I'll stop there as kind of an overview of the undertaking we're involved in, and happy to answer any questions later.
Thank you, Paul. I asked Paul to take a couple extra minutes to make sure everyone understood the Beltline and its significance. And I have to note that Paul is not trained in public health. So he's an urban planner, but you would not know that from his comments. And I think it speaks to the potential for health in all policies, where we do bring together different disciplines to work for a common cause. So, John?
As Mike said, I'm with the American Cancer Society, which has grown to be the largest voluntary health organization in the world. We have 6,000 professional staff. We have 3 million full-time volunteers. And the American public last year gave us just shy of $1 billion. 90% of that comes from individual voluntary contributions. A year ago, this past January, we published for the first time, we have an award-winning series of publications, but we published for the first time a year ago in January, Cancer Facts and Figures on Survivorship. When our organization got started 100 years ago, there were very few cancer survivors, so we didn't need to publish anything then. But we did last year, and today there are 28 million long-term cancer survivors in the world. The United States of America has 5% of the world's population, but that's the home for 50% of cancer survivors. So we have made progress, and I want to make 2 points. One, it's amazing how much we've achieved with such a poor investment in prevention science. It's a remarkable thing to think about. And so we are making progress, and I can look you in the eye today and say most of the people suffering from cancer today and who will die, 1,500 will die today in America alone, are suffering and dying needlessly. And so the sense of urgency has to be turned up greatly on the importance of prevention science and prevention research and prevention implementation. Think about this. Well, first, let me say, we have the Framework Convention on Tobacco Control. I was advised in Washington a number of years ago with a number of other execs behind closed doors by tobacco experts. Don't go for it. Don't go to Geneva. Don't participate, because the U.S. alone will kill this thing before it ever gets anywhere. If it weren't for Derek Yach and Grow-Brundtland, we wouldn't have FCTC, but the first public health treaty in all of history, and it's making a hell of a difference. 180 countries ratified it?
177, yeah.
177. Unfortunately, my own country hasn't done that, but that's another story. But we need to think big, and we need to infuse many more resources into prevention research. And clearly, if we've come this far without doing it, think what we could do if we do the right thing. A case in point, much of our data we do have, we're the only world-class intramural cancer research program in an NGO. In our cancer prevention study number 1, we're now into cancer prevention study number 3, but our cancer prevention study number 1 data was a part of the original Surgeon General's report in 1964. And that document by the IOM and other people has been noted as perhaps the most important scientific document to come out of a government agency in all of history. If we, the American Cancer Society, had, the day after that was published, invested more money in prevention, I would argue, and others would do likewise, we probably would have solved the tobacco problem here. 8 million lives have been saved since the original Surgeon General's report, but it could be, we could have realized Chuck Coop's vision of a smoke-free society of the year 2000 if we'd done the right thing. Shortly after I was in this post, we went to the board and said, look, we've got this incredible basic research program, but we need research in other areas. And they passed a resolution to balance our portfolio and to invest a lot more into behavioral research. We have a behavioral research department within our organization, and it's making a difference. But if we'd only done some of these things sooner. So I'm talking now as an NGO. One of the things I said at the high-level meeting on non-communicable diseases, one of the things we can bring to the table is a spirit of advocacy to do the right thing, because we're not conflicted. We're only trying to do what's in the best interest of public health. So I'll stop there, but simply say one point that has been alluded to, but maybe not stressed as much as it should be. It's an economic imperative that we do far, far more with prevention. So we announced, again, last January, the first ever 20% reduction in age-standardized cancer mortality rates in America. 20 years, year over year, the cancer death rates have gone down, and now it's reached 20%. That 20% reduction is a $10 trillion economic value to the American people. Put differently, the UN high-level meeting points out that if we sit on our hands, if we don't invest more into prevention, and most of this progress, that 20% reduction, the lion's share is prevention, as a result of people not smoking and having screening tests and so forth. But think what it could be. The high-level meeting points out if we sit on our hands and we don't invest into prevention, we will see a $47 trillion lost in economic output in the next 20 years. So just at a time when the world can't afford that. So the bottom line is that we know a lot in demographics. I love demographics because you can be so precise. I can guarantee you that in 15 years, I'm going to be 15 years older than I am today if I'm still alive. But am I able to take care of myself, or am I disabled? And so the investment in prevention science and prevention policy, in my opinion, has never been more important for this country or for the world.
Great. Thank you, John. And Rob?
Thank you. So As a function of experiencing the great comments, excuse me, from the speakers, panelists, and the audience today, the comments that I prepared for today's symposium are no longer as interesting to me as they were. Those comments had to do with a belief that I have that an economic model, an economic architecture, a market architecture to this topic is probably more useful than a pure academic architecture to public health as it relates to reducing the incidence and prevalence of chronic diseases, obesity in particular. So I posted those prepared comments on my blog last night. If that if the interplay between economics and market and academia and public health interests you, then you can find that on my blog. So what am I substituting for those comments? So I heard the word evidence a bunch today, and in fact, Derek's charge, I think, was, what can we do in the industry, Kaiser Permanente, CDC, whatever. What can we do in the industry to increase the evidence of public health improvement and improving the health of the citizenry? I've also heard the word science a lot, so I'm gonna pick up there. At Kaiser Permanente, we know a boatload about improvement, in particular, tempo of improvement and spread of best practices. So it's one thing to create a best practice or to discover a best practice through the scientific method. It's quite another to spread it to the doctor. It's created in one doctor's office, spread it down the hall or across the street or in the next county or across the United States. We have been historically in our industry very poor, very sluggish in spreading best practices. So yeah, evidence and science are important, but this is a little bit heresy here saying this at a university, but I'll tell you something that I think is more important, and that is creating evidence in a lower cost, more rapid manner than the traditional double-blind, placebo-controlled crossover trial that takes 10 to 12 years to do, millions of dollars to accomplish, and is often imperfect in its conclusions, sometimes contradictory in its conclusions. So at Kaiser Permanente, we achieve evidence and spread best practices through a much quicker, lower burden thing known as the Rapid Improvement Cycle, or PDSA, Plan, Do, Study, Act. And there's lots of literature out there if you're interested in it, lots of literature about how to apply that to public health as well as other areas of the industry. What else do I want to say? Number 2. Science does not sell. There have been a few comments by panelists and speakers and also the audience just scratching at this surface so far this morning. The idea of, well, maybe we just need to create a little bit better educational content or a fancier PowerPoint slide or a handout that is more culturally appropriate for the target audience, and that is going to change the behavior of humans. Well, it turns out that there's a lot more that we know today about how humans make decisions regarding their behavior than we knew in the past. And it ain't our frontal lobes. It's not the cognitive process of listening or seeing evidence, weighing the pros and cons, benefits and risks. That's not where humans make our behavioral decisions. We make them in the limbic system. If you want evidence about this, then read Shankar Vedantam. Shankar Vedantam is the neurobiologist and social biologist correspondent for NPR. Wrote a book called The Hidden Brain. It'll blow your mind. Or if you prefer behavioral economics, somebody talked about behavioral economics earlier today. So there's a guy at the University of Chicago, what is his name? John List, who wrote a book called The Y-Axis, but it's W-H-Y. He's spent his entire career on behavioral economics. Freakonomics, everybody's heard of that book. I hope you've read it. There's market-based and belief systems at the basis of every action that a human takes. As scientifically minded as I am, as entrenched as I am in the scientific method and academia and data and graphs, here's how I have bought every car that I've ever purchased. I decide which one feels right to me by sight before I even set foot in it. Make that decision, buy the car, and then I go to my 20-year subscription for Consumer Reports to validate the decision that I made. And you know, so I'll leave it at that. But here's one in the brand and marketing space. So I'm going to give you two examples of this. So in the 1980s, the tobacco industry needed to increase, from an economic standpoint, its penetrance in adolescent uptake of tobacco use. So they had empirical evidence at the time, what we now know today, that adolescent decisions are not made in the frontal lobe, but rather in the limbic system. It's true for all of us, whether you're an adolescent or not. I'm not being disparaging about young folk. And they further knew that they had to create a character, a vehicle, a cartoon vehicle, to appeal to the limbic system of adolescents. And this vehicle was going to have their product dangling from the mouth, but I'll assert to you that seedless grapes could have been dangling from the mouth of this character, and adolescents would have purchased that product and consumed it. But it wasn't seedless grapes hanging out of Joe Camel Cool or Joe Cool Camel's mouth. It was a cigarette. And man, the velocity of initiation of tobacco, of smoking tobacco, went through the roof in the 80s and early 90s as a result of Joe Camel. So, you know, so that's a dark example of how brand and marketing and an understanding of human behavior might inform public health strategies today. Here's another one. So I'm sitting next to a great colleague from the American Cancer Society. John, I would be interested in hearing, so it was reported this week, John knows this better than I do, it was reported this week that the death rate of colon cancer has gone way down in the last 10 years. And there appears to be a causal relationship between that declining death rate for colon cancer and the rising consumption of colonoscopies. So do you believe that an educational program or a handout increased the consumption of screening colonoscopy in the United States? I don't. I know, I believe, whether it's true or not, I believe I know what caused colonoscopy uptake to go like this during the last decade. Katie Couric. Katie Couric having a colonoscopy on national television. You know, so there's things that we can learn about how to get the American public to consume supply, demand, and consumption of better decisions, food, fitness, and flu vaccines. We can learn something from these past examples and from the science of behavior and decision making. It ain't about random, double-blind, placebo-controlled trials.
Right.
Number three. In most venues where I'm asked to talk about public-private partnerships for successful public health outcomes, the example that I historically proudly use is Beltline, is Atlanta Beltline. Having Paul at the table today, I don't have to do that. So I'm going to pick a different one, and this one is called Georgia Shape. Georgia Shape is a statewide public and private partnership headed by the Department of Public Health, Brenda Fitzgerald and Emily Vall. And let me point out one institution that has made a terrific investment, historical investment in reducing childhood obesity, and that's Children's Healthcare of Atlanta. And Children's Healthcare of Atlanta, Kaiser Permanente are 2 of 20 public-private institutions that are part of the Georgia Shape Initiative. We have bent the trend on the rise of childhood obesity in Georgia. It's beginning to decline. Now let me weave in this concept of, rather than a randomized double-blind placebo-controlled trial, small tests of change and applying the science of improvement and the scientific method to small tests of change. In the Georgia Shape, and I'll also weave in brand and marketing on this example. So there was one site, an elementary school in Cobb County, who ran a small test of change. They created a Zumba class for the kids first thing in the morning. And so they supplied a activity that created a demand for that activity, and the kids consumed that activity. And what they found was that the kids who consumed that activity, their test scores, their standardized test scores went up, their attention improved in class. This is, you want to talk about evidence in science, there's plenty of science that says that activity in class improves educational outcome. What have we done as a state with regard to physical education? Over the last 10 years, we've eviscerated it out of the budget and out of our curricula. Anyway, here's my point, that the people at the school who figured this out went to the teachers and says, boy, do I have an intervention for you. If I could guarantee better attention and better standardized test scores, you, teacher, would make a bigger difference in the lives of your kids. And oh, by the way, you're more likely to get renewed in your contract next year because of No Child Left Behind. So the intervention was clear. The brand and marketing appeal to the target audience, in this case teachers, was clear. And the science supporting it was pretty clear as well. All right, enough about Georgia's shape. The last thing I'll say, Derek, about 10 or more years ago, I'm told, you are instrumental in appealing to the WHO and getting the WHO to recognize that an important part of the health of a community has to do with the absence or reduction of violence against women and children. And I had the opportunity to be part of the launch last year of another campaign, the No More campaign, NOMORE, that seeks to increase awareness and reduce the incidence of sexual violence, in particular against women and children. And I'll assert that just as valid as flu vaccines are, and campaigns to reduce the consumption of saturated fats, and to be more fit and to breathe clean air, I'll assert that healthy relationships should be an important part of the agenda, focus, and prioritization of things like the Vitality Institute and what we do at Kaiser, or what the CDC does, or whatever. So I just ask us to think about healthy relationships and reducing violence against women and children as at least as equally valid as some of the other scientific things that we've talked about.
Thank you, Rob. Somehow I've managed to blow the time schedule here, so you need to rein me in, keep us on here. I know Ursula may have to leave, so I'll give you the opportunity to, if you have to take off, please do so. And then just turn it over to Rhonda for a thought-started question or two, but somebody who knows the time of what we actually have to accomplish, give me a signal about where we are. So Rhonda, let me turn it over to you to kick off the conversation. And
well, thank you very much. This was really enlightening and pretty exciting. I'm very excited about the Beltline. I'm hoping you're measuring graduation rates and all the other stuff in the surrounding environment that you could be measuring, because that, I think, as our last speaker just said, is probably as important. Somebody once told me that it does not take overwhelming evidence to change policy. It takes sufficient evidence and political will. And since I am the person on the commission who still lives in a state where they haven't outlawed smoking in restaurants and public places, I live in rural Kentucky, I can tell you that that's absolutely true. But what I'm asking each commissioner, what is one thing, what is the one piece of evidence you think would be most valuable for us to either find or build that might actually change policy on this? And I'll start with you, Ursula, because you're leaving first.
I won't leave first, but I will go first. That's right. So someone here said evidence isn't what sells the policies, and we're certainly struggling with that at CDC. And I think the history of tobacco control tells us from 1964 forward. I mean, we have had evidence after evidence after evidence that smoking is not good for our health, that actually severely harms our health, that is associated with huge economic costs, and yet there are competing interests and there are competing values that really prevent us from generating that political will. where we are able to make progress is where we are able to embrace that culture of health, to let go of our sort of acceptance of a second-rate health status that I think we've eased into as a nation. We're much more concerned about our choices than we are about our health status and our longevity. So for me, the issue isn't finding the magic bullet piece of evidence that's actually going to finally convince people to do the right thing, but how do we embrace the value of health? How do we communicate the evidence that we already have in ways that people can understand and personalize and make decisions around?
I would add to that, and I hate to put this in such blunt terms, but so much of what we do is predicated on public perception. And that's kind of where I took Rob's comments to go, which is, at the end of the day, despite the fact that we all want a healthier environment, decisions within the marketplace and even amongst government entities are largely driven by economics and to some degree personal health, not public health. And environment is like number 7 or 8 on a list of 10 objectives, which means from a market standpoint, it's never going to get the attention it deserves. So we have a cultural disconnect between a huge amount of evidence around the environmental effects of what we're doing and a marketplace largely driven by emotional decision, impulse decision making that's not paying attention to it. Having said that, there's plenty of evidence to show that there is greater prosperity in quality communities that identify values to the marketplace that create healthier and more economically vibrant populations, and that then ultimately drives a lot of the decision making. And so when we're looking for greater evidence, we're often trying to inform in a very curious way the marketplace, which is naturally driven to succeed. So for them, it's a race to the top with competing agendas largely driven, unfortunately, by government, which creates restrictions of the marketplace, which results in a race to the bottom. So that disconnect needs better evidentiary sources to bridge the gap between those two audiences and empower municipalities. And Rob and I were chatting a little bit about this at the break, to have better informed, thoughtful decision-making about the consequences of their policy making, so that they actually recognize, and not telling them what to do, but just making sure on health agenda items, they actually know what the consequences are.
John?
I would just add, I think that question is very difficult to answer, but if you push me, I would say we need better science on how to solve the disparities issue. And Derek mentioned it earlier in his comments, if you don't change some of these underlying conditions, it's just another problem comes in after you take care of the hookworm. The World Bank has observed, and these are big issues to say the least, but the World Bank says even though it seems like everything's in a bad way, we have made some progress. There's less hunger in the world than in all of recorded history. There's less, it's hard for me to believe this, but they say there's less internecine conflict, actual active wars than all of history. And they say more people on the planet have more freedom than ever before. But disparities have gotten worse. So I think, and actually the two areas where we're clearly losing, globally I'm speaking now, not in the U.S. necessarily, is disparities in tobacco.
Nothing to add to what the other panelists have said.
Well, before I ask another question, this is my opportunity, but are there anybody else who has a question for this very distinguished panel? Yep, there's one.
Oh, there's a mic coming, Bob.
I'm Bob Robinson. Well, I couldn't let an opening like tobacco and disparities pass me by. The larger issue of Derek's mission, which is to advance the science of prevention. I disagree that schools of public health are doing a good job. They may be the only ones doing the job, but that doesn't necessarily mean they're doing a good job. And by that I mean, when we think about prevention, we think about populations, we think about policy, and then we automatically segue to youth. And what we need to do is step back and ask the question, what's missing from the prevention map? And I would suggest that one of the important components that's missing is community. That we have a very atheoretical appreciation or understanding of what community is, and therefore the science and the applications that are targeted towards community. Len Syme, for example, will tell us that when we look at community-based research interventions, very few of them have significant outcomes. And I would say that one of the reasons for that is that our science, our understanding, our theory, and our methodologies relative to communities are insufficient, atheoretical, and backwards. Tobacco and disparities. We have a raging public health success in this country. African Americans in 2001 eliminated the black-white disparity gap. Why? Because from 1990 to 2001, their rate of decrease was 2 times that of whites. The reasons for that have to do with actually quality leadership. Michael Eriksen was director of OSH when certain programs were put in place. Jeff Koplan was head of the National Chronic Disease Prevention Center when those programs, and the American Cancer Society really helped facilitate and disseminate certain of those programs that were initiated. So, my challenge, if we are in fact talking about advancing the science of prevention, is how do we in fact critically view what we're currently calling science and begin to actually add and do the work, do the research, do the methodological work, do the theoretical work that is so essential to, in fact, raise our bar as far as prevention is concerned. And that is the only way that we're going to tackle the problem, John, that you just referenced. And we're not going to do it without a more coherent understanding of community.
Yeah, I would, thanks, Bob. I would just segue from what you said to what Paul's presentation was around the Beltline, which is actually a natural experiment that's going on. And the question needs to be raised, is it being evaluated sufficiently to really learn the lessons that could impact the rest of the country or the rest of the world around community involvement and engagement and participation in something that is, in many ways, a very much of a program, an applied program to make a difference, but is it getting the investment to determine the impact of it that actually could advance progress? And that's a question I think that it would be a good one to leave with the Commission for their consideration. So I know that we're running out of time. Let me get a signal from someone. We're okay? Okay.
She says we're dead.
We're dead? We say, both of whom used to work for me, one tells me, this is the way it is every day at work. One says, okay, the other one says, cut it off. And I say, but we all work in that environment. So let us thank the panel. And invite Derek back up to the podium for some closing remarks and last discussion.
Let me thank the speakers on the podium and the moderators. I know when I stand between you and some lunch and also a chance also to have some social interaction outside, it's time to be brief and really I'm not going to give a summary. I think there were a number of high points that came through for me. I think from the Commission's perspective, a really important one I think, is the point Bob mentioned at the end, this issue of the structure of our science, focusing very easily, and I think it came through very well from Rob and others, in a clinical trial setting, very badly if we're really interested in whole community effects. And yet we saw a demonstration of a whole community effect from the Atlanta Beltline, which will clearly have hugely cascading effects. What is the appropriate way to study the impact on that on health? Clearly, it may have bigger effects than any clinical trial dreamed up. And what other approaches are there across the country? I think when we think about infrastructure investments as major opportunities to change many aspects of prevention, we infrequently evaluate them and think about all the urban development and urban design going on in this country around the world, which each creates an opportunity to actually look at the cascading impact on better work performance, changing activity, and so on. So that's something we need to think about how we build into our programs. I think many of the other speakers highlighted the importance of the way we communicate, and that's also something we need to give great emphasis to. The very language we're using is still not joined up enough. I think that we had some interesting perspectives on private-public interactions. The concerns around trust and distrust exist on both sides. Interesting discussions that some mentioned the centrality of government regulation and leading, others showing the dangers of government regulating and killing off incentives, innovation too early. And getting that balance right is something we need to think about. And finally, I would just say that the centrality of health and development and the centrality of prevention to health is something we all agree with. And I think we all have a shared frustration that we're not doing better at it. I just hope that as we start building out the messages and recommendations of the Commission, we can share them with you, not to get fine tinkering on the points, because I don't think that's what's going to be needed. What we do need from you is an idea about how we're going to cascade these messages into every possible community setting, every possible leadership setting, that we're reaching the right people in the best possible way. And we will be gearing up to be able to do that, to make sure this is not a report that's going to be sitting on a dusty shelf somewhere and be picked up later. That's not our goal. We really want to get a movement going and hand it over to people to take the actions that they think they can take based upon the evidence. And I would like to just answer one I guess, a slight challenge from Jeff to say on the health metrics one. So are there companies who are actually going to do this? I think Ron knows there are companies geared up and ready to do this. The entire Johannesburg Stock Exchange will probably be the first stock exchange, not just to encourage major companies to report health metrics, but to require it. And under the South African integrated reporting law, this is very possible. So a year from now, I have no doubt, our CEO will be standing, maybe you'll invite him here to say, our annual report is out. We're showing good profitability in all our markets. We're starting to show strong revenue growth in every market. We have a slight problem with the body mass index of our employee base. And the shareholders and the investors will go, what the earth is this guy talking about? And then he'll say, well, of course, this is the most important source of capital in our company. It's the most important resource we have. And if we can't get on top of it, our long-term growth, competitiveness, well-being, morale is going to deteriorate. Therefore, we are reporting it and we're encouraging all other CEOs to do the same. And I suspect that we will see some progress. So let me thank, first of all, Georgia State, Michael Eriksen, just really fantastic to have worked with you, and this is just the start. And your team, Ellie, Julie, Francis, Shonde, Trevor, and I believe there are many others. From Emory, Jeff, thank you enormously for your support and Alice's help as well. We believe that catering the talk of the town will give us something to talk about outside, hopefully. All of the speakers, Carrie Andrea from way out in San Francisco, who did a lot of the behind-the-scenes organization, and two key people from my own team, Elle and Gillian, for making this all happen. So let's just see this as the start. And this is the hotbed of prevention in the US. Let's try and see how we can build out even more from here. And we look forward to working together and sharing something to eat outside. Thank you all.